already? What do you? Yeah.
But I left it 4 to 5, 4:30, 4 to 5, and it's still.
Yeah.
Did you find it okay?
Yes. I did the scouting yesterday and this morning.
I wrote a lot of circles and circles and circles.
Well, that's what happened to me yesterday.
Oh, okay.
Because I couldn't. This place is covered over by trees, and I couldn't see the numbers.
It's an old place.
Yeah.
Very
I think I need a blanket. We can hold it.
well, we spent it here because we can like go in the park.
I don't control them. Just the boat.
Okay, so headings are out.
Toothbrush and toothpaste. Oh, isn't that? Oh, what else? And a shopping bag. It's a nice bag.
Nice and clean and new, as opposed to all mine that I have in the car at all.
Dirty and scummy.
Plastic ones even in that. Well, Anthony came at the end of the video. Candace's husband.
Yes.
I said, hey, sorry, we're peeking at when the cops picked you. He said, oh no, it's okay. He says, he's one cop that knows me really well. I said, okay. He says, and he was just giving me a bad time because he didn't have my registration and my license and my insurance card. He said, so he was just giving me a bad time. And I said, well, we were going to surround you, grab you, bring you in, and say you are a patient.
Yeah.
If you look like he's going to arrest you. They really are. And you know, he wasn't able to get rid of it. It's just the way the bone is and everything. And so he gave her some, he says he thinks it's the there's no one on that side. So he gave some fix it in. I felt bad because I really wanted to be really good.
I know, but it's a lot better than what you had.
Well, yeah, but I really wanted to be.
I know. But,
I don't know if you know this person. Years ago, yeah. About 3 years ago. Yeah. Well, no, not this year. No, she hasn't done this year.
no, she's been very good about her appointments.
About 3 years ago, she tried, she has a pregnancy modification. And she got this guy, and about 3 years ago, we started trying to get her to go in and very
quilt book and start reading it through.
Could have. Did you like it?
Well, I looked at it when it was at
Yeah.
Book Names, but Joanne had gotten it. And
Oh, it's
then,
not the one that was at that woman's thing?
oh, I got that one already.
Oh, well, this is a different.
This is a new one that Joanne had
Oh, what's this one?
script book. Scrappy script book. You know, great paddles. They're gorgeous. So I'll bring it in.
Last night I got home, and I said to John, there's asparagus, and there's meatballs that are pre-cooked in the freezer. So we went to the store and he bought a huge thing just to rice burger. And white. So you're reading that now? It's kind of
I'm glad I still have it. There's 4 of us. Thank you.
Maybe something like this would give you a recipe. Yes.
Is that one of those packaged meal?
Yeah, I've had a couple people say they're really, I have never tried it, but I've had a couple people
I
say
had
they're really
Blue
like
Apron.
Yeah.
I really liked Blue Apron until they relocated our distribution center to Sacramento.
Oh.
And then the meals were just not great.
Oh.
But I know
Right.
someone who did the Hello Fresh.
Right.
But she lives in Chico, so
Okay.
you know.
Right.
And she said it was just awful.
Oh, they were fabulous.
Yeah.
When they used to be at Oakland, I was getting them, their ice was still
Yeah.
packs, etc. But it's just such a wonderful opportunity to try different things without buying the big spicy or something
Yeah.
you're going,
Well,
but I got a little sick of kale also.
it's the amount of packaging that is within is one of the things that negatives, and that they're trying to work now so that you send the packaging back.
Yeah, Blue Apron had that. You could send the packaging back.
Yeah.
And so all the little containers and all the different things, yeah, you could send them back. Recycle that.
Yeah.
I found it to be very helpful. Just the right size box.
Right size
So
box
my
for everything.
garage is still full by Christmas ornaments with the Blue Apron boxes.
You know right where they are.
Angela tried it. I don't know which one they tried, but they really liked them. Eric and Angela.
Oh, huh?
From my nephew from Arizona. They tried it and liked them.
What's it called? String pull?
The one that we had in class. The one that, the new one. Because I didn't really open it. The package is on the bed. Oh, that's lovely.
That would be when you do it.
You have that foundation for it.
You probably do.
Yeah.
Good. You know what I find interesting? Start off. And you put, now all of a sudden you get to So, she's coming, but I don't know, we can put 5 and 10.
Well, how can you sit there still talking?
I went around the block and
I did too.
here and see the sign. It's very liquid.
It was very difficult to find. Well, why don't you just sit right there?
I'll just sit back.
Just sit right behind you. Okay. So you lay down stripping and you sew one side.
Ladies and gentlemen, thank you so much for your patience. Our buffet dinner is served, so please don't enter anybody in the aisle in the stampede.
No. I forgot to get silverware. I'm closing this door.
So, this morning, I had asked my friend to do that. Why don't you go to the store, see the stuff separate, to add to the stuff.
I don't think her car, I don't know if her car is Bluetooth ready or not.
If it is, she'll answer it. If it isn't, she'll answer it.
Good evening, everyone. I know some of you are still getting your dinner. I appreciate that. We're going to have a little short presentation about the situation with the Santa Rosa Junior College and their dental assisting program. Without further ado, I'm going to turn the microphone over to Mark Ryan, and he'll go from there.
And I will soon turn this over to Carol Hastrick over at the JC. I just want to make the dental community aware of some changes that are going to be happening at the junior college, especially as it regards to the dental assisting program. You all have flyers on your tables that refer to that. And then I'm going to pass this on to Carol to give you a little bit more background and detail.
Thank you. Thank you very much for welcoming me here. And my name is Carol Hattrick. I'm the director of the dental programs at Santa Rosa JC. And I asked Martin through Mark to give me an opportunity to speak to you for a few minutes about some of the facts about what's happening at the JC so that we're all clear on what we're doing and hopefully can stop several of the rumors that are already starting to fly around. So I've given you an informational flyer regarding what we're doing. Our dental assisting program has seen a reduction in applicants and therefore enrollees over the last 4 years. The JC is concerned enough about that they're suggesting to us that if we don't have enough applicants for this year, we will be closing the program or putting it on hiatus. The applicant pool needs to be 20 people. We have 15 right now, so we'll see what happens. Our application pool ends in the beginning of March. I wanted to show you what we're doing in order to try to make this an easier program or a more applicable program for our graduates and for our community. We've closed our CODA accreditation program, which takes away some of the prerequisites which may have been barriers for dental assistants to come in, and we've made this into a 2-semester program, so it's a fall-spring program. With that, the candidates will be eligible to sit for their RDA exam with the state. The second thing I wanted to make sure that everybody knew is that the hygiene program has not changed. The hygiene applicant pool remains approximately 3 times as many applicants as we can accept. So I've already received a couple phone calls and emails from prospective hygiene students wanting to know if they could get into the hygiene program right out of high school, and they've heard that all the prerequisites have been waived. That is not the case. The hygiene program is still a CODA approved program and requires all the prerequisites that have always been in place, with now the addition of one more, thanks to our Dental Hygiene Board of California, who wants all our hygiene students to also have a math requirement. So that's not changing, but the dental assisting program is changing. And I invite any of you who have questions to take a look at the flyer. Up in the left corner, there is the website for our program, and certainly gives you an opportunity to get in touch with me if you have any questions. And if you have applicants who are thinking about being dental assistants, we'd love it if you would send them our way. We're going to be coming around this summer with some advertisement for offices if they're willing to put it out on their desks in their reception areas. What we found is that you, as the dental offices, are our greatest source of applicants. People seem to think that you look like you're having a good time, and they want to be just like you. So they come to our programs thinking that they are going to be one of you, and in fact, they become one of you, because I see some of you out there. Thank you very much.
Thank you.
Thank you all. That is a very serious issue. It's something that we've all been supporting. We want to see, I would like to see continue, as if I had a say in anything. But I mean, I think it's important that all possible applicants be brought forward and see what they can do. Our speaker this evening is Dan Pompe from Long Island, New York. He and I are fellow New Yorkers, I guess, at one time. So he's an oral surgeon, and I didn't realize you were retired, but it's he's has a list of credentials which are all on the flap of your flyer. And he was in California on another matter and was good enough to come up and speak with us this evening. Without further ado, I give you Dan Pompe.
Thank you. Thank you very much, Martin. Thank you for having me come up here. This is my first time presenting in California. I'm 65 years old, the first time I made it out your way, so I'm very happy to be here. I've been in Los Angeles, in Hollywood, in Beverly Hills, and I'm going to, then I went to Ventura, now I'm here. We went to San Francisco, then we're going to go back down to San Diego, so we're really getting in a lot of your state. And I have to say Things you hear about in New York, about California, all not true. You guys are fantastic. I have never been treated so well, and I'm very thankful for that. So I'm an oral surgeon. I retired 7 years ago, and I retired to basically do this. So I lecture all around the country, now in South America and Canada and throughout Europe as well. This is my main topic, medical emergencies, although I have 6 other topics, which you can see on my website. But this is my favorite topic. And the reason it's my favorite topic is because during these last 7 years, I've received at least 15 emails. And those emails have said, basically, it's because I took this course, and this is the full-day course now. We're going to get a little abbreviated version of it tonight, that in taking that full-day course, we saved someone's life. So there are things that I'm going to introduce you to today that are not like other medical emergency courses that you take. Specifically, I worked during those 7 years up until now with multiple EMTs. And these fellows, guys and girls, both have taught me some very good street-smart approaches in dealing with medical emergencies, not things that you get in the usual dental literature. So I'll share those with you today. Just to give you an example to start off, how many of you in this room are comfortable starting IVs, intravenous anesthesia, intravenous? So by a hand, I see 1, 2, okay, which is usually what I see. It's about 1% or 2% of dentists and dental hygienists are in that category. So I'm going to introduce to you 4 medications that you can now use that you administer intranasally. So as long as you know how to administer Aspirin, okay, to yourself, all right, for a cold, you can administer these 4 drugs, which in the past, some of them had to be given intramuscularly or intravenously. So that's a big breakthrough. And also, I have a technique that has been shown and has worked out for many people where when we're in an emergency, it's hard to really react well because we're under a lot of stress and a lot of pressure. And I have a little kind of a way to get out of that stress and pressure by just memorizing certain things. What are those things? Colors. So I have color-coordinated associations with different emergencies. And by the time we leave tonight at 9 o'clock, you're all going to know exactly what every color is. And I'm also going to be testing you because I have, about 10 prizes to give out tonight. And these are prizes that are going to be directly related to my topic, like pulse oximeters, like glucometers, which I think every office should have in their armamentarium. So without further ado, this is the title of the lecture. I love the Rolling Stones. Rolling Stones here? Great, okay. So back in 1973, the Rolling Stones came to New York City, to Madison Square Garden, where I saw them a few times now. And in order to get tickets for that performance, you had to send in a postcard. You couldn't just like go and pay for the ticket. So I sent in, so I met a girl about 2 weeks before this, and I sent in about 36 postcards, hoping that one would come back so that I could go and purchase the ticket. The only one that came back was her first name and my last name, and we just met. So basically, we had to get married in order to go to see the Rolling Stones, and that's been my wife now for 46 years. So I made the right decision, and thanks to the Rolling Stones. So Colgate is supporting me today. That's why you all have a little prize in front of you, and you don't have to wait online or listen to a 1-hour presentation. Colgate is very generous, and they've given you these prizes and little things to go home with. So we thank them for that as well. So this is New York City. This is where I was born and bred. I did my residency here, and I went to college, high school, and postgraduate studies. This is coming into Manhattan, so I was really River in a few minutes. This is Central Park, and this is Central Park. Today. So, like to start me up. It's 6 o'clock at night, so we gotta get started. Thank you. Forest Hills, which is in Queens, one of the 5 boroughs of New York. And the reason I chose to have a practice in Forest Hills is because if you look at if you consider Forest Hills to be the center of all of the boroughs, you are actually 20 minutes away from Long Island, Manhattan, the Bronx, and Brooklyn. The center is Forest Hills. So anyone in all of New York, all the 5 boroughs could get to my office in 20 minutes. And it turned out to be correct. So it was really a great place to be. I have to put this up because I'm going to tell you that you're going to learn things today that you haven't heard before, and the best thing to do is to really practice them. I'm going to make the PDF available to you of the lecture, so all you have to do is just send me a request for it, and I will send that to you. This is a little bit of background information about me, but I'm not putting that up there to brag. I'm putting up to here. Layla will be done. Okay, that's the last thing we'll be hearing, all righty? So, you know, a lecture like this, sometimes people look like this at the midway point, and I often give this as a full-day lecture from 9 to 5. Sometimes it gets really bad that people look like this, and it could really even get to be this point. So I'm going to try to not have that happen tonight, and you hear people say things like that. So what I'm going to try to do is work with your brain a little bit tonight and get it to really get into the topic, and I'm going to ask you questions, as I said. So these questions will test your memory and test your thinking skills, and those of you that get the questions right will get some of these. I hope to have you look like that by the end of the presentation today. So to start with, I'd like you to all salute, okay? And I don't mean a salute like that, but I mean a salute like this. So if you could all put your right hand up and salute to your temple, and you just make me happy by doing this. I really appreciate it. Okay, so hold that spot, and I want you to drop that hand to just below your clavicle. Okay, and then with your left hand, put it just below your belly button. Just below your belly button. Okay, we're all together here? Okay, so now you know the positions to put the pads for an AED if you have a person in your office that has a cardiac arrest. So now you all know that. Now, how many of you have AEDs in your office? By show of hands. Wonderful. Okay, and it's not required in California, am I correct? Or it is required? It's not required, but yet about 90% of you have it. Very impressive. It is required in New York, as it also is required in 28 states in the United States. And one of the reasons why an AED is required is because the likelihood of a person who has a cardiac arrest ever coming back to see you for another appointment is 4%. So you have a 98% chance you'll never see the patient again, not to mention the family and the people that love that person. So you really have to have an AED in your office if you want to have that person survive. Where's a safer place than a dental office to have a cardiac arrest? Does anyone know? Shopping mall? No, maybe. Airport? Good, but not as good as this place. Who's going to Giant Stadium? No. Why Giant Stadium? All right, no, you want to know the answer? It is Las Vegas. Because if you have a cardiac arrest at a table in Las Vegas, you know all those cameras that are above? As soon as you hit the table, they are there to get you. Why? Because they want to make sure that you lose a lot more money and you live. So they want your business, and they are going to make sure that you survive a cardiac arrest in Las Vegas. But a dental office is pretty maybe even the second most likely chance of surviving. We have, if done correctly, we can have as high as an 80% chance of survival for a person having a cardiac arrest, compared to 4% if you don't have an AED. So that's where the pads belong. So we'll talk about the positions that I told you about. The brain, in dealing with a medical emergency, there are two areas of the brain that we want to concentrate on. One is the median temporal lobe and the prefrontal cortex. 80% of the time, we're in the median temporal lobe. It is the intuitive or emotional part of our brain. 20% of the time, for most of us, we can get into the deliberate or logical thinking part of the brain, which is called System 2. Now, when you're dealing with a medical emergency, which part of the brain do you think you want to be in? You want to be in the deliberative and logical thinking, but we're almost always in this part, this median temporal lobe. But there's something that happens when a medical emergency occurs, and you all know what that is. The System 1, which we talked about, median temporal lobe, System 2, prefrontal cortex, and System 3. This third system only works to do one thing, to switch you from one to the other. It's just like a light switch that goes on and off. And System 3 allows switching from one to the other, System 1 to System 2. There's a big problem. The big problem is, you will see, that System 3, when there is high levels of epinephrine, is not accessible to us. So we cannot go from emotional thinking into logical thinking when we're dealing with a medical emergency, because our adrenaline is pouring out of our adrenal glands and into our system. So that's a problem, and I'm going to tell you how to avoid it. Okay, so how we respond to stress. Back in 1929, Cannon first published the material on fight or flight. In '86, LeBroy, fight, flight, or freeze, because that's basically what we all do. Unless you're EMTs, unless you're emergency room physicians that then retired and became a dentist and or a hygienist, unless you're in that category, which I don't think too many of us are in, you will basically freeze dealing with a medical emergency. It is human nature to do this. There's an article on my website by Renaud, who is a practicing oral surgeon in Paris, and he talks about this whole concept with system 1, 2, and 3. But I'll tell you about a friend of mine named Harvey, a general dentist, who has taken the full-day course 5 times in the last 7 years. Not only has Harvey taken the full-day course 5 times, he's also taken it with his wife and some of his staff, but he's a good friend of mine. I go out to dinner with him. I go to his office in Queens, and I'll be waiting in the waiting area before he finishes his day at 5 o'clock, and it's like 4:45, and he says, Danny, do me a favor. Go over to anyone in my office and ask them what they would do for any medical emergency. And this includes the receptionist, the office manager, the person that sterilizes the instruments, his hygienist, anyone in the office, of which he has about 7 people on staff. And I say, come on, Harvey, I don't want to do that. I don't want to embarrass them. He says, no, go ahead. And I do, and guess what? Everyone in his office knows what to do for every single emergency. They have the cards memorized, which you're all going to have by the end of today. And I said, Harvey, this is great. Why do you do this? And he says, well, I'll tell you 2 reasons why, Danny. Well, number one, what about if I'm the person that has the medical emergency? I want to know that there's going to be someone there that can save me. And number 2, I know I'm going to freeze. So you see, Harvey is the most honest of us because he admits that he's going to freeze before he freezes. And I will tell you that he's had multiple medical emergencies in his office, and he did freeze. But what happens is, when he has the people around him know what to do, he comes out of it. So he'll freeze for a second or 2, but then 1 or 2 will say, this is where we have to do, this is the color, let's get on the algorithm and move, and he's back. Okay, so it's a very good lesson to be learned. By the way, I could tell you that there's a dozen offices throughout the country now that have their entire staff trained exactly as Harvey does. So that's a testament to that. So the ultimate emergency that occurred in recent times was this.
Birds. Whoa.
How they heal.
One going back. We have both of them going back.
He's saying that there's multiple impact. Now watch what he says to his co-pilot. He tells him to look at the quick reference guide. Okay, you see that? He took out the book, and the part that's interesting about this is that Sully wrote the quick reference guide. Okay? Those are the kind of people you want in your office working for you, and those that are in your office. You want people that are objective and that are serious and that deal with the situation right as it's occurring. You know the rest of the story. All 101 people aboard safe, and they get together every year and they celebrate with a party and they celebrate life. This is what Sully said, by the way, after this. He said, I spent my life making small deposits in the bank of experience. He says, so that when I needed to, I could make a large withdrawal. I would actually put a very large withdrawal into that statement. And, but the point I'm making is that he actually wrote that quick reference guide that all the pilots use to take out when an emergency occurs. And even though he wrote it, he still told his co-pilot to get out the quick reference guide and let's start going through the list. So the person who's the most knowledgeable and experienced, he goes with the book as well. And I'll tell you how we're going to use it.
I think it's time we stop, children. What's that sound? Everybody look.
Cortex, you have to stop what you're doing because that prefrontal cortex cannot multitask. You need a quick reference guide, or in our case, it's going to be color-coded cards. You have to focus because the prefrontal cortex cannot multitask. And one way to have a favorable outcome is to practice mock emergency drills. I'm not going to ask how many people do mock emergency drills because I know not a lot of you do, but that's the only way to get comfortable in dealing with a medical emergency. And the way you do it, I'm going to tell you, is this. Unless you're immune to something that I had in New York City through my 30 years of practice, there's something that occurs every once in a while, and it's called the famous cancellation. And when you have a cancellation and you're down for a half an hour or an hour, that is your time to do a mock emergency. Have someone in your office get lipstick, red lipstick, and put it across their head or their neck. And don't tell everyone in your office this is happening, but put that person into an operatory and say, so-and-so is having an allergic reaction, let's help them. and see how your staff responds to this situation. And you're going to notice that there are some people that can't wait to get out to go to the bathroom, and there are other people that come right up to you and say, what could I do to help? And it's good to know who's who before the situation occurs. And that is one way that you will know who is who. And you want to know the people that are going to be there to help you, because they're going to be there the next time and the next time. There's something, in an emergency, there's something called the sterile cockpit, which means it restricts and forbids any casual conversation. You've got to get really serious in a situation like this. The checklist, which would be the color-coded cards, which I'll talk to you about, and something called closed-loop communication. In an emergency, you can't say, someone get the AED, someone get me the emergency kit, someone get me the epinephrine. You have to say the name of the person, and then that person has to say your name back and that they're doing what you asked them for. So I'll say, Mary, get me the EpiPen. And Mary says, Dr. Pompe, I heard you, I'm getting the EpiPen. That's called closed-loop communication, and you have to do that in the mock emergency. So you practice these things during that. Here are the color-coded cards, and what I decided to do was to make a different color for every emergency, because you can remember the color, but you won't remember what to do for each emergency, and I'll tell you why the colors are what they are. White is because you'll see the whites of their eyes as they faint, or they turn white as a ghost. White. Red, what's the color of blood? Red. So anything that's a cardiovascular emergency, cardiac arrest, angina, will be the red color. What's in the sky? What's the color of the sky? Blue. What's in the sky? Air. So any type of a respiratory or respiratory problem will be the blue card, like asthma. The most severe emergency that we can have is the color green. Why? Because I think of it as the lights. Red, orange, green. When it hits green, what do? We have to hit the gas and go. So green to me means go, and not just go, but move quickly, because if you don't move quickly during this emergency, your patients are going to die. And what is that emergency? Anaphylactic shock. So green is severe allergy anaphylactic shock. And the last one is yellow, and yellow is a little hard to remember, but yellow is you're not quite awake, but you're not asleep either. You're in between. It's called AC, which stands for altered consciousness. So AC, altered consciousness, is the yellow card, and I've given you the explanation of the others. And LOC is what I use for the white card. That stands for loss of consciousness. So here we go. I want you to just look at that for 30 seconds. Just read it. And by the time we leave tonight at 9 o'clock, everyone's going to have this memorized. And I'll give you the color-coded cards just by sending me an email, and I'll be happy to send it to you. All you do is you hit the PDF print and put it in a color printer, and out will come the cards in the colors that are described over here. My suggestion is that you laminate them and then put them in your drug emergency kit. By the way, all of you have a drug emergency kit in your office, and you all spend about $1,000 a year on the reordering of the drugs and setting it up. I'm going to show you before the end of tonight how you can probably spend a third of that amount and maintain the same drug kit, if not better than what you get today. So these are the colors, and blue would be the sky, which is the respiratory, breathing emergencies. So this is my email, and this is my website. So dpompe, OMS for oral maxillofacial surgeon @gmail.com. All you got to do is just say, hey, I was here today, and just send me the PDF and send me the, you can say, send me the whole 9 yards, and I'll send you the color-coded cards, and I'll send you articles that I've written about this. So this is the Raynaud article. Back in 2014, there was a fellow named Craig Miller. And what Dr. Miller did is he published this in the JADA, Journal of the American Dental Association, and in it, what he did is he took people at random that were going to different clinics throughout the United States and that said that they had no medical problems. They said they were healthy. And what he did is he decided at random to drug test them as far as urinalysis and blood tests. And what he found, and these are people that said they had no problem at all, what he found was that 83% of the patients had 1 or more abnormal readings. So you think that your patients are fine when they tell you they have no medical problems, but I will tell you that many of them are not. 1 in 5 patients had significantly abnormal readings in LFT, that's liver function tests, and creatinine levels, which indicate kidney dysfunction. So why is this important? The reason why this is important is because, well, we'll talk about kidneys specifically. For every year we are over the age of 40, we lose 1% of kidney function. So if you're treating 90-year-olds, which I treated many in my practice, right off the bat, they have 50% loss of kidney function. So when you're giving things to them like antibiotics, narcotics, even local anesthetics, they're not clearing those drugs the way your 40-year-old patients are clearing them if the 40-year-olds are healthy. So you have to realize that given certain limitations in kidney and liver clearance, you have to reduce the dosage and or the interval of time that you're giving these medications to our patients. I have a link that gives you this, by the way. People that have kidney disease, that's chronic kidney disease, CKD, if their glomerular filtration rate, GFR, is under 60, or if their creatinine levels are over 5, so those are the magic numbers. You don't have to take a picture because it's on the PDF, but you're welcome to take the picture, no problem at all. So that's the magic number. GFR under 60 and creatinine over 5, then you have to consider reducing their dosage and or increasing the interval of time. I have about a 12-page link for you to send to you that lists all these medications for people with that particular problem. Again, just ask for the whole 9 yards and I'll send that to you. So longer elimination times, reduced dosage requirements with age as therapeutic levels may approach toxic levels. Again, that's my email. So we have shout outs today, which you just shout out for bragging rights. And then I have the prizes, which please raise your hand because, as you know, I don't know anyone here. So I don't want to choose one person over another. Whoever's hand goes up first will be the first person I'll call for the prizes. Okay? So let's talk about this, index of suspicion. This is something that physicians, our MD colleagues, have developed a lot better than we do, unfortunately. And what this means is that when you hear something, you associate it with something else. So for instance, if a person says, "Doc, you know, all of a sudden I don't feel my fingers. Okay, I have numbness in my fingers since I woke up this morning and before I came to your office." We might think you want to adjust the temperature because it might be too cold in the room. But the truth is that there are 18 reasons why a person has peripheral numbness. We'll talk about some of them today. Causes of seizures that are not from epilepsy, we'll talk about 4 of them. When to give supplemental oxygen, we'll talk about 10 reasons. Because one of my main things is not only to help you with a medical emergency, how to deal with it, but it's how to prevent the medical emergency from occurring in the first place. Because if you can prevent it, you don't have to deal with it. And I will tell you that dealing with it is very stressful to all of us. Syncope, causes that are iatrogenic. We actually cause there are 6 reasons why we actually cause a patient to faint. So peripheral numbness, here are some things. Hypoglycemia and hyperglycemia. So when your blood sugar is really low, and or if you have peripheral neuropathy from very high blood sugar from long-standing diabetes, you could have peripheral numbness. Hypothyroidism is one of the indications for, one of the things to think about with peripheral numbness. Hyperventilation, so someone who's breathing really fast, hyperventilating, they might say, "I'm not feeling my fingers," but it's a subclinical level of hyperventilation. Hypertension, extreme hypertension can cause peripheral numbness. So right there you've got 5, all in the hyper and hypo situation. All of these can be a cause of peripheral numbness. So here are 2 unusual causes of loss of consciousness. We all think when a patient faints in our chair, it's why? Because they're afraid of the dentist, or they're afraid of the needle, or they're afraid of feeling pain, right? That's how we approach a person who's fainting. But I'm going to tell you 2 reasons now, which you may or may not have known. One is this, hypoglycemia unawareness. And what is that? Diabetes today is becoming the biggest increasing disease in the history of the planet. Within the next 10 years, about half of the United States will be pre-diabetic. Right now, the last census showed that there were 86 million people in the United States that were pre-diabetic. And pre-diabetes, what does that mean? How is that defined? It's defined as an A1C level between 5.7 and 6.4. Once you're 6.5 in your A1C level, then you are full-blown diabetic. What is A1C? That's the amount of sugar that's coated on your hemoglobin, and it's a measure of your sugar over a period of 3 months. So it's much, much better and more accurate than a blood sugar level, which is just taken at the moment it's taken. A1C levels you don't have to fast for. You could all find out what your A1C level is by going to a local drugstore, CVS, Rite Aid, or Walgreens, and buying an A1C tester. It costs about $45, and you get 2 tests per kit, and you're welcome to test it on yourself. As a matter of fact, since June 1st of 2018, the American Dental Association now has a new code, and that code is a code for testing people for A1C. I'll show you what the code is in a few minutes. You can do it in your office. There are certain guidelines that you have to follow. You could find those guidelines on my website. But hypoglycemia unawareness, what is this? This is people that usually are diabetes type 2 and have multiple episodes of hypoglycemia because of the different medications they're taking. So they go hypoglycemic often, and when it happens so often, they almost become callous to it. They can just go unconscious from being conscious instead of going through the normal signs and symptoms, which are what? Shaky, sweaty, tachycardia. So instead of the normal things that a person has, you know, they're disoriented, they're belligerent, they're angry at you, they're confused, they look like the deer in the headlights look. So instead of all that, they'll be talking to you, and the next thing is, they're unconscious. And you might think it's because it's a syncope because they're nervous of being in the dental office. But no, it could be this. And if you just treat that person, when they leave the office, they may wind up getting in their car and killing someone, or, you know, killing themselves. Another one, urinary tract infection with a diabetic patient, usually elderly females. Urinary tract infection, they are long-standing diabetics. There's peripheral neuropathy. They're not feeling anything. And with the high white blood count, they can actually go into anything from loss of consciousness to hallucinations. And this can happen right in your chair. So again, you're going to give local to an elderly diabetic female, and all of a sudden she goes out. Your thought is that it's syncope. She may come out, but no, it was a urinary tract infection, and she was diabetic. So those are the two correlations, elderly, diabetic, and female, that this can occur. So those are two things to add to your list of things to not to realize. Of course, having a glucometer would be pretty helpful, which I'm going to give 2 people tonight, and I have 4 pulse oximeters to give out, because you can test their blood sugar very simply with this glucometer. By the way the companies really get you is they charge you nothing for the glucometer, and then you have to pay $100 to get the test strips. So don't get your glucometers in that way, but go to your local drugstores like CVS, Walgreens, and Rite Aid, and get their brand of the glucometer. So you get their brand, and look at the side where it says 10 free test strips included, and that's going to cost about $25. So that's something that you should all have, and get their brand, and you'll save significantly. So first sign of or index of suspicion of a medical emergency is altered consciousness. It's almost always the first sign, and the first sign of altered consciousness is confusion. So if you know your patients well, which I'm sure all of you do, when they're not showing signs of being normal and they're confused, like you ask them what movie they saw this week and they tell you what the score was in the baseball game, you know there's something wrong. They're confused. So that's the time where you want to think or raise your index of suspicion that a medical emergency might be developing here. I wrote an article in 2014. This is the title of it, Update on Basic Physical Diagnosis. You're all welcome to the article. It's on my website, but also I'll send it to you. It's only about 4 or 5 pages long, and it talks about some of the basic testing I'll tell you about that you can all do. So who's going to tell me this? This is bragging rights. You don't get any prizes for this, okay? What's the #1 emergency in the dental office? And before you answer that, I'm going to tell you the #1 medical emergency in a medical office is not the same. In fact, the #1 emergency in a medical office is asthma and asthma complications, and that includes pediatric medical offices as well. What's the #1 emergency in a dental office? Right, okay, well that's the standard answer that you hear in all the textbooks. I'm going to tell you that I look at it a little bit differently, and I'm going to tell you what I think it is. What I think it is I think it's the person that comes into your office with hypertension, not just a little hypertension, severe hypertension, and you didn't take a blood pressure. And that patient gets treated and leaves your office, and somehow they didn't have a stroke. And I will tell you that I gave this lecture in Pennsylvania a few months ago, and there was a person there who told me that they had a patient they treated on Friday that they took a tooth out for, and the patient died on Sunday. And on Monday, the medical examiner was there asking them to see their records, and all they wanted to know was one thing. Did they take vital signs? And the person took a blood pressure, and the pulse, by the way. And that was perfectly normal. So that's an important thing, to make sure to take blood pressure. The old days, blood pressure hypertension was 140/90. Now 130 and over 80 and over is hypertension. In fact, if you have 120/80, that's called pre-hypertensive. How many of you know that? 120/80 is no longer normal. You have to be 119/79 to be normal for blood pressure. All right, so you have to be below 120 and below 80. And that's pre-hypertension, and then you have the urgencies, 180/120, and crisis as well, 180/120. How many people here would treat someone with 180/120 blood pressure? But I got news for you. If you don't take the blood pressure, you're not going to know. There's no sign that says HTN, hypertension, that they walk in with. They don't look rosy red. They're not sweating. They don't have typical signs and symptoms. So there was a study that was done to show this called the Sprint study, and in it, back in 2015, they figured this out, that when you can get a blood pressure below 120/80, you have 25% less stroke and 27% less mortality. It's not that the drug companies want to get more drugs out. It's that the truth is that these numbers really save lives. they actually had to stop the study because the difference in people that were living versus not was so significant. They had to stop another study, by the way. Do you know which one that is? The one with statins. When statins were being introduced to the drug environment, it was such that the people that were on statins versus not were living, and the people that were not on the statins were not, and they stopped that study as well. So with low blood pressure, reducing the risk of heart and kidney disease, stroke, and age-related declines in memory and thinking, that was the original purpose of the SPRINT study, but the result was that they realized that anyone under 120 had less medical problems and strokes. So those are our numbers. And to realize that hypertension is not a young person's disease, between the ages of 18 and 39, only 7.3% of the population has hypertension. Very few. But when you get to 40 to 59, 32%, and 60 and over, 65%. But that was until November of 2018 when the study came out. And now we're realizing that if you're over 60, it is 80%. 80% of the population has hypertension. And if you're African American, it's about 100%. So realize that the people that are having hypertension are much more than you thought. And taking a simple test like that is so simple to do, just taking a simple blood pressure in your office. So this is what is written in the drug insert for local anesthesia. So take a look at that. Careful and constant monitoring of cardiovascular and respiratory vital signs and the patient's state of consciousness should be performed after each local anesthetic. That means after every local, and hygienists in California are giving local anesthesia, correct? Okay. So hygienists, you are in this category as well. It really is required that you take a blood pressure, and not taking it is not a good idea. Because if a person does have a complication, you're really, you don't have a leg to stand on. So unless you're as good as Neo in The Matrix, I think what you're basically doing here is you're dodging a bullet, because one day you may get hit, and unless you're as good as Neo, he can get away with that, but you may not be able to. So hypertension in age, as we get older, we all have an increase in blood pressure. Although there was a study that was shown with, I think, Australian postal workers that walk 7 hours a day, they're immune to cardiovascular problems and diabetes. So I don't know how many of you could leave your practice and walk 7 hours a day, but that happens to be one of the ways that we could do that. Hypertension, 50% of Americans will be over 50%, especially when you're over 60. 3/4 of those who have their first stroke have hypertension. Over 2/3 of individuals who have their first heart attack have hypertension. So you could really screen people so significantly to prevent them from having these problems. But here's the good news, everyone. The Dental Society has now shown that up to 25% of dentists are now recording blood pressure. Is that good? Guess what? That's not in the United States. That is in the country called Pakistan. In the United States, I don't think the number of dentists that record blood pressure is more than the number of people that floss. What do we think that is? Anyone want to give me a guess at the number of percentage of people that floss routinely? I think it's about 10%. Am I reaching too far with 10%? Do you think it's less or more? 12%, really? Have you actually seen a study that said it? So that's about the percentage that we're taking blood pressure for. Now, it's interesting because when I give this course to students that just graduate dental school, it's 100%. They take blood pressure 100% of the time. It's as we get out of that mode from dental school and get older and older and get more complacent. Well, part of the good thing about that is that the older you are and the more established your practice is, the less you have emergencies. I guess it's something to do with your comfort with the patients and the patient's comfort with you. They're less nervous. There's just less syncope episodes that occur as opposed to younger practitioners. Signs and symptoms of hypertension. There's nothing that they don't come in with a sign, as I said. Headache, typically a dull pain in the back of the head on waking up in the morning might be an indication, and it's a good question to ask in your questioning of patients in the beginning, and there's something I have that's called the Conversational History, which I'll get into in a little bit. But that's also a sign of carbon monoxide poisoning, brain tumor, and sleep apnea, having a dull ache in the back of your head in the morning. So it's not pathognomonic. These are the typical signs of a hypertensive crisis, from a headache to shortness of breath, but people are not going to walk in your office with all these conditions and want to be treated for dental problems. So that's the other end of that. Even if controlled with medications, still you're more likely to have complications of hypertension, which would be what? End organs. Well, I'll first tell you about this, how to prevent hypertension. That is weight loss, minimum of 30 minutes a day of exercise for 3 10-minute cycles. Alcohol use, that first glass of wine, and boy, how more appropriate is that in this area, right? That first glass of wine, it's actually good for you. It'll bring down your blood pressure about 5 points. But when you ask for the second glass of wine, it goes up 5 points. So if you can have the discipline to always never ask for a second glass of wine when you go, by the way, I try to explain this to the waiters or waitresses. They don't really want to hear about it for some reason. Cut down salt intake, that's one of the biggest things. And our British colleagues, and you know, in England, granted, dental IQ is not as high as the United States, but we have learned some interesting medical things from our British colleagues. And one of them is this. They did a study from 2003 to 2011 where they decreased the consumption by 15% of salt, and they found it was a 42% reduction in stroke and a 40% reduction in heart disease. Note, only 10% of the sodium is in the salt that we add to our food. So end organs of hypertension are what? The brain, the heart, the kidney, and the eyes. These are the same end organs as affecting us in what other disease? Who's going to tell me? Exactly, diabetes, okay? So diabetes, eyes, kidney, cardiovascular, nerves, and teeth. Let's talk about this. Remember we talked about A1C before? 6.5 and over is diabetes. 5.7 to 6.4 is pre-diabetes. Most diabetics are over 6.5, almost all. You have to keep an A1C level of 7 and under. This is with medications for a diabetic to not have retinopathy, meaning problems with your eyes. You have to be below 7 to not have problems with your kidneys. You want to be below 6.5 to not have cardiovascular problems. And you want to be below 7 to not have neuropathy. What does this mean? Well, since it's almost impossible for diabetics to be under 6.5, and you have to be to not have cardiovascular problems, that means practically 99% of diabetics have cardiovascular problems. There was a study that was done called the Maastricht study that showed that even in pre-diabetic state, there's retinopathy occurring and affecting the small vessels under skin. So even in the pre-diabetic state, there are significant problems that are occurring. Neuropathy, let's talk about that. So if you have peripheral neuropathy, you don't feel normally as far as peripheral nerves. Let's say if you're having a myocardial infarction. And what are the typical signs? You're going to feel pain in your jaw, pain in your neck, pain going down your arm, pain in your pinky. But if you're a long-standing diabetic and you have peripheral neuropathy, guess what? You don't feel that. You don't get that. What do you get? A person who's a long-standing diabetic who's having a myocardial infarction in your office might say, you know, I got a great night's sleep last night, but I feel like I have the flu or I feel completely fatigued right now as they're sitting in your chair for the first patient in the morning. That may be a person having an MI. 25% of guys that have an MI don't know they're having it. It's called a silent MI. The percentage of silent MIs that occurs in females, 50%. Half of women having an MI don't know they're having it. They know because they go to the cardiologist or their doctor, they get an EKG, and they see an inverted Q wave on that. So diabetes is the big thing. 86 million, but that's as of the last census taken rather. That's going to be significantly going up. How do we know? Why are we having this problem with diabetes? Because our BMIs are way too high. Over 30 is considered obese. That is the body mass index. How to measure your BMI? You take your weight in pounds, multiply that by 703, and divide that by your height in inches squared. Now, don't do this right now, please, okay? But I will tell you that the numbers are excessively high in the United States. This is the percentage we talked about. It's increasing significantly, especially in that 60-year-old category and over. So, average person with type 1 diabetes experiences hypoglycemia up to 2 times a week. If untreated or ignored, this can go to seizures, coma with the potential for cardiac arrest and death. So causes of hypoglycemia that you might not think about: missed, delayed, or inadequate meals. This is after you take medication. Excessive insulin or oral hypoglycemics, excessive exercise, or alcohol use. So in other words, they take their medication, they eat, or not that much. They may have some alcohol before they come to see you because they're nervous to come to the dental office. They may have some alcohol. That'll bring their blood sugar down. Or other people might go to the gym and work out because that relieves stress as well. And if they go to the gym on their way after taking their medication in your office, they may go hypoglycemic in your office. And what I'm going to tell you about is what is easily had in New York City, not exactly here, but you have your own environmental problems as well. I call it a BSS. A BSS stands for a blizzard storm scenario. What that means is, in New York and the whole Northeast and many parts of the United States, you go to work in the morning, there's a couple of snow flurries out there, and by 2 o'clock in the afternoon, you have 2 or 3 feet of snow outside your office, and that's when you have your medical emergency. You have to be prepared for that, because when you call 911, and by the way, not on a cell phone, but try to call on a landline because it gets through faster and more direct, you say, I have a medical emergency, it's a diabetic patient, they've gone unconscious, okay? Maybe even having a seizure. And they say, well, we'll be there, but we'll be there in about an hour or an hour and a half. But we'll be there. What are you going to do for an hour and a half? Well, I'm going to tell you what you can do, okay? And you can all know this before you leave today. You can administer that person who's hypoglycemic and unconscious an intranasal drug, 1 cc of it. It's called glucagon. And this is what a 1 cc administration of a drug looks like. And I want to put this under a light so you can all see this easy. I'm sorry, I'm going to get you a little wet here. Okay, you ready? This is 1 cc of a drug injected into the nose. That gets into your system almost as fast as an IV. And until now, you didn't have that option of using an intranasal drug to save that person's life. Now, granted, the likelihood of you having a person go unconscious and there being a blizzard storm scenario, especially in Sonoma, is very rare. But there are other things that could happen, weather issues or problems, and you might have that issue of an emergency and you can save their life. Using 1 cc of glucagon will raise the blood sugar on a person 250 milligrams. So that is a significant way you can save someone's life. Periodontal evidence. This is interesting. Back in 2008, there was an article that said, evidence suggests that periodontal changes may be one of the first clinical manifestations of diabetes. So we, as dentists and hygienists, are on the forefront of possibly diagnosing someone in a pre-diabetic state even better than their own physicians. And a lot of people don't go to physicians, but yet come to us. That was done in 2008. I'll give you an example. You take a tooth out, and you see that patient 1 week later for suture removal or just as a follow-up, and the tissue looks like you just took the tooth out, and it's 1 week later. The first thing you should be thinking about, index of suspicion, remember iOS? This person's got diabetes. Have that person go to their physician, get a blood workup, and or if you have a glucometer in your office, use it. A1C tester in your office, use it if you have that as well. So I'm going to give you what the code is for that. Here it is. It's D0411. And going to a hygienist and or a dentist and having a good subgingival cleanings because of the degree of inflammation that occurs when you have subgingival plaque is significant. You can go up to 6 times a year if you have high A1C levels and are diabetic, and enhanced programs, enhanced medical benefit programs, you could be approved for up to 6 times a year going to have a cleaning. And that can considerably help your A1C levels. It's been reported to be up to this level. I can't really say for sure it is, but the medical literature has shown that it can go down. And decreasing the inflammation can also decrease your A1C level. So it's a win-win. Now, the only state that's been approved that they actually do that for, where they're reimbursing people for A1C testing, is in New Jersey. And it's through the company called Delta Dental, but only through a select number of people. It was a beta study. I think it actually may be over at this point. But some people in that state were being reimbursed for testing in their office. That is now, I believe, passed. And it's going to be evaluated to see the efficacy of how that works in changing the people's lives in Jersey that have pre-diabetic. This is an article that I wrote just last year, and it's called Dentists and the Dentist's New Role in Recognition and Screening A1C in-Office Testing as an ADA Procedure Code. And it's a 2-page article. It's very simple. I'll send it to you. All you got to do is ask for the whole 9 yards. Okay, and I'll send you that as well. So what are the leading causes of death in this country? Unfortunately, number 3 is medical error. That's pretty sad when you think about it. The number 1 is heart disease, cancer, then the new category of error, chronic respiratory diseases, accidents, and stroke. And as you can see, this is mostly cardiovascular in nature. Then we'll talk about Alzheimer's, diabetes, influenza, kidney disease, and suicide. If you take diabetes and kidney disease, which I underlined, because the number 1 cause of chronic kidney failure is people with diabetes, so you add this and this category, and it puts you onto the first page somewhere around 4 or 5. So you can see how significant diabetes is becoming. And it is now really a pandemic around the world. So subjects I'm going to talk to you about today, you'll see a little notebook pad like that. And, oh, sorry, let's go back. Sorry, here we go. And how many of you know why I'm playing that, right? That's the beat that you use when you're doing CPR, 100 beats per minute. It's also the same beat as in Staying Alive, in Staying Alive. But that actually part of the movie was an homage to the movie back in 1953 called Strangers on a Train by Alfred Hitchcock. You can see the scene taken from the knees down as an homage. And then what's interesting is that that was Robert Walker. I run what's called the New York Classic Film Club in New York City, where I show films from the film noir era, which is the late 30s and 40s. And what I try to do is I try to get descendants of the people that made those films, like the grandchildren of the screenwriters or the actors, come in and tell us a little story about the movie that's never been heard of before, like something that you would read on IMDb in the trivia, but not listed in IMDb on the trivia. And it works really well. We have about 100 people come. I give about 4 films a year. And I was a minor in film, by the way, when I was in college, so at NYU, so I really love that category. But Robert Walker, unfortunately, who was that person, died of an anaphylactic reaction after being treated by his physician right after making that movie, Strangers on a Train. And because the physician did not have epinephrine to reverse that problem. So you really, I know 2 people, 2 specialists, one periodontist and one pedodontist in New York, that actually had anaphylactic reactions occur in their office. They actually came to this lecture before those occurred, and they knew exactly what to do for those reactions, and the people that had them both lived. So 3, 2. Lecture, and they think, am I in the right lecture? And you absolutely are. So why do I show that? The reason I show that is because I cannot watch Top Gun and or Apollo 13 without having something happen to me. And I hope it happens to some of you as well. And that is that my adrenaline starts to go soaring to the point that the hair almost stands up on my skin. And that's my segue to teach you about adrenaline, because that is the #1 drug you need in an emergency kit to save people's lives in 2 emergencies, one being an asthmatic attack that doesn't respond to albuterol, and 2 being an anaphylactic reaction. But we have to learn a little bit more about epinephrine. So I'm sorry, but I have to take you back to Physiology 101, back when we were in dental school and training for being a hygienist, to learn about epinephrine. So it's very simple. It really is not difficult. How many hearts do we have? Good. Those of you that didn't know that, I think you need a cup of coffee. With 1 heart, any receptor that ends with 1 has to do with the heart, and it has to do with increasing the heart, meaning increased blood pressure or increasing the heart rate. So if we have anything that ends in 1, a beta 1 here and an alpha 1 here, that means it affects the receptor with the 1 ending to increase the blood pressure or increase the rate. Now, how many lungs do we have? Great, okay. That would be anything ending in 2 has to do with your lungs. By the way, how many pupils do we have? Okay, so it also has to do with the pupils. So 1, epinephrine, heart rate, and contractibility. A1 is B1 is increasing the heart rate and cardiac output. A1 is increasing the peripheral constriction. So peripherally, the smooth muscles in the vessels constrict. That'll squeeze the blood peripherally, which will do what to our blood pressure? Increase the blood pressure, because everything is being squeezed into the central, so our blood pressure will go up. But this is an interesting one, and so is A1, by the way. In a second, I'll explain that to you. B2, relaxation of the smooth muscles in the lungs. So you're having a laryngospasm, everything is constricting, you can't breathe, but epinephrine will open you up. So that'll save you in an anaphylactic reaction, and also a severe asthmatic attack. But it also causes, in the pupil, causes the ciliary muscle to relax, which results in far vision focus, and there is a dilation of the pupil. So what does this tell us? How many of you watch the Poker channel, or maybe go surfing through the Poker channel and watch for a few minutes, and you see a bunch of people sitting around the table, and what are they wearing on their face. They're wearing sunglasses. Now, you think they're wearing sunglasses because they didn't get a good night's sleep, or they didn't put their makeup on, or because they want to look cool? No. They're wearing sunglasses because they don't want their opponents to see their pupils dilate when they have an epinephrine rush. For whatever reason. It maybe they have a great hand to bluff, or they have a great hand, whatever. But when those pupils dilate, you can't control that. That is an epinephrine reaction. So that's why they wear sunglasses. So now you may know something that you may not have known before. So let's talk about the good and the bad with epinephrine. There's a lot good, there's a lot bad. One of the things that we need to create a memory is connecting the prefrontal cortex and the median temporal lobe and an area called the amygdala in the back of the brain. And there's synaptic glue that is necessary. And that synaptic glue to connect those parts of the brain and to create the memory is what? Epinephrine. So when you have an experience that's really traumatic, like a woman being raped, like a guy or a woman seeing their buddy blown up next to them in war, the epinephrine that is expressed into the body is so high that it makes that memory that you have to deal with the rest of your life, post-traumatic stress disorder. So it's possible if you block the epinephrine, which is the synaptic glue, you don't have to necessarily live that the rest of your life, sometimes every minute, every hour of your life. So how do you block it? What did we just talk about before with the receptors, alphas and beta, right? So there's a drug called what? A beta blocker, right? So if you can get an intravenous beta blocker like atenolol to block the epinephrine, and you get that relatively soon after that traumatic event, you don't really forget the event, but what you do is you disassociate the epinephrine reaction to it, which is, remember, shaky, sweaty tachycardia. So you can disassociate the memory, and you're going to have less of a memory, but you also disassociate the physiologic response to it, which gives people the post-traumatic stress. So that's a significant improvement that we now can offer people in that situation. Index of suspicion, now let's talk about epinephrine as it relates to our local anesthesia and people that are taking these beta blockers. So if a person's on a beta blocker, that's called a non-cardioselective, so cardioselective and alphas are okay, but when they're on a non-cardioselective beta blocker, which means beta 1 and beta 2 blocked, what's opened? We just talked about the different receptors. Beta 1, beta 2 blocked. What's the one that's left, remember? Alpha 1. Okay, alpha 1's open. Okay, now tell me who remembers what alpha 1 does. It does the what? Peripheral constriction. Okay, so what does that do? It increases the blood pressure. Okay, so now let's say a person is given an epinephrine injection, right, and there's epi in your local, and they're beta blocked. The only receptors that are open are going to be alpha. What happens to their blood pressure if you get it into their blood vessels? Going to go up big time, okay? So let's just assume that you didn't take a blood pressure on this particular person that we're talking about, and this person, let's say, had a blood pressure of, let's say, 100 diastolic. And now some epinephrine gets in, they're beta blocked. Only thing that's going to get them is their alphas, right? So their alphas is going to cause their blood pressure to go up. How much do you think they can go up? It can go up a lot, and it's at the expense of the diastolic pressure more than the systolic pressure. So these are common beta blockers. Again, the list is available to you. Just send me a request, and I'll send them to you. This is an example of a person who's not beta blocked, what happens when they get epinephrine into their blood vessels. What happens? They all say, my heart is racing so fast, my heart is going to feel like it's bursting out of my chest, right? They get a fast heart rate. Okay, exactly right here, going up almost 50. With a pulse going up almost 50, with a significant decrease in systolic diastolic as a compensatory reaction to keep them alive. Well, what about when they're beta blocked? Look what happens. The diastolic, represented by yellow, can go up almost 40 points. So if you have a person that you didn't take a blood pressure for and their diastolic is 100, and they go to 140 diastolic, what could happen to them? With a stroke. They could wind up having a stroke. Now, how often does this happen? Well, it's not really reported that much in the dental literature, but it is reported in the ophthalmic literature. There are cases reported where people are having ophthalmic surgery, beta blocked, get epinephrine, it's intravascular, and they wind up having a stroke and die. So it happens. You have to be careful with people that are beta blocked. Here's the good news. The good news is if they're taking their pills, it's rare that they're ever going to have high blood pressure to begin with because they're taking it, and the result is their blood pressure will be lower. But it is possible. Another thing to avoid, by the way, especially with people that are like this on beta block, is to enjoy PDL injections with vasoconstrictor, especially with people that have cardiac dysrhythmias. So red light should be flashing with some of these drugs as well. I'm not going to go over every one of them, but I'll just take one, and that's Neurontin. Neurontin, or gabapentin, is one of the most abused drugs in the United States today. This is being taken for people that have epilepsy, people that have postmenopausal symptoms, people that have restless leg syndrome. And what happens is that Neurontin, when combined with heroin, makes it such that the addict takes less of the heroin to get the same high. So people abuse this gabapentin and take lots of it and take it with less heroin and get their high. If you wind up having a patient who you give local anesthesia to with epinephrine, and you get the epinephrine intravascular in people that are abusing gabapentin, that person will have a seizure in your chair. So be careful and look for this and ask people about the use of this drug, because when it's abused, you have a potential for a problem. What might you do? Not use epinephrine in your local, or use it carefully. Make sure you're always aspirating. So this is you in the morning, listening to opera, and you're getting ready to give your first local anesthetic. You're going to give an inferior alveolar block. And as you look back there, all of a sudden you see that uvula, and that uvula is moving. It's actually pulsating like this. Is that me? Oh, okay. So it sounds like that. It's pulsating. Thank you for the prop. And see, we timed this before. And it indicates that something called Muller's sign, a pulsating uvula. I'm going to show you an example of what that looks like right here. Take a look at that uvula, and you're going to see, go. See it pulsating? It's an indication of aortic insufficiency. These people are subject to shortness of breath, chest pain, and if you have that before you're ready to give your local, I would say probably not do the procedure, especially if they don't know that they have aortic regurgitation. And it's also associated with a widened pulse pressure, which means that the difference between systolic and diastolic pressure is not 40. Normal, 120/80 is the difference of 40. When it gets to be 50, 60, 70, 80, 90, that's called a widened pulse pressure, and it's associated with aortic valve regurgitation, hypertension, and hyperthyroidism. So this is an example of what we're talking about with aortic regurgitation, that the leaflet valves are not working well, there's backflow of blood, there's more shortness of breath and chest pain in people that have this. You could pick that up with that simple finding. Decreased pulse pressure when it's less than 40 between systolic and diastolic, aortic stenosis and mitral stenosis, just to keep things complete. All right, so who's going to tell me the number here for our first prize, which is going to be a nebulizer with albuterol? So you got to raise your hand. I saw your hand first. So GFR below what and creatinine above what?
GFR below 60 and creatinine above 5.
Right, very good, excellent. Okay, that was, I'm glad to, I normally throw these, so in the future I'm going to be throwing them. I'm giving you a warning, everyone, all right? Very good. Index of suspicion. Now, this is an interesting one. This is very interesting, actually. In 2008, there was an article, I believe it was 8, I'll show you the article in a second, where there's an association that's found between hypodontia, people that have missing laterals and or peg laterals, because peg laterals are a hypodontia situation, like this, and the correlation exists between that and epithelial ovarian cancer. This goes back to the BMP, bone morphogenic protein. There's 2 and 4, I believe, are the 2 that are involved. One is in ovarian development, another is in dental development. Both BMP products. I'm going to read to you what the article says right here. The prevalence of hypodontia was 20% in EOC subjects and 3% for control. This means that the potential for people that have epithelial ovarian cancer is 8 times greater to have missing laterals and or peg laterals. And you can actually wind up saving someone's life if you pick this up and there is a very strong connection between and correlation between that person and their mother having epithelial ovarian cancer and or in their family. EOC is also associated with the BRCA mutation gene. A person who has peg laterals or missing laterals, congenitally missing laterals, or bicuspids or third molars, whose grandmother, mother all died of breast cancer and or EOC, epithelial ovarian cancer, it might not be a bad idea to have them genetically tested. This is not our domain as oral surgeons and general dentists and hygienists. This is the domain of OBGYN. So you might bring this to the attention of them, because I don't think many of them know about this correlation. And you'll find, and I've found in giving this talk around the country, how many people tell me about that they have this association. So, you know, having the surgery done, as Angelina Jolie did, is a significant, significant procedure. But the chances of dying from breast cancer with the positive BRCA mutation go down from 82% to 2 to 3%. So that's an amazing difference. And we could pick some of that up with this very strong history of hypodontia and strong family history. That article, by the way, is on my website. And you're welcome to just, again, say, can I have the article, or just go right to my website, which is this, www.aps stands for Advanced Practice Seminars, 4, the number 4, dds.com. And if you go to that, you'll go to an area right here where it says Publications and Reference, and you'll get a drop-down, and one of those drop-downs is the article that I just mentioned. So we got to get a little bit light because this is very heavy to do at night after you're having a little dinner here. So who's going to give me 2 reasons or 2 activities you could do to prolong your life? Part of this lecture is how to save your own life. Okay, so this is the first part. We'll talk about that. So who's going to give me 1? Everybody says exercise, and it's basically true because it, extends our life as far as keeping weight down and also creates these temporary insulin receptors, so it brings our sugar down, which is another factor. What about this one? You think so? Well, everyone that takes the nap says yes. No. What about this one? This is the only one that's 100% true. Okay, and unfortunately, think about it. It's not a common thing to live a very long life and be morbidly obese. So, reduced respiratory rate. What about that? Well, think about the Dalai Lamas. Think about the Tibetan Lamas. They all breathe somewhere around 4 times a minute. 4 times, and they all live to 100. So actually, if you could bring your respiratory rate, which we all have at about 14 to 16 in that range, if you could bring that down to 4, 5, 6 a minute, you could live a longer life. What about this, having a dog? Yeah, especially, this is my wife, this is my daughter-in-law. They have a golden doodle, which I will tell you is probably the most intelligent dog I've ever seen. Of course, those of you that have your dog feel that it is the most intelligent. And any dog, any color, this is my other son, this is my daughter-in-law. This is my kids and their wives, and laughing a lot I think is so important, which is why I think it's so important when you go to sleep at night to not listen to the news, but to watch, Curb Your Enthusiasm or Seinfeld episodes or The Honeymooners or something, just to get your mind off the, stress of the day. This is the theme song to a show that was my favorite show in the late 70s, early 80s. Does anyone remember what it was? You have to be 65 and over probably to remember this. It was called St. Elsewhere. Super show, wasn't it? It was just a great show. That was followed by another show called Hill Street Blues, which is also the greatest police show that was ever done. So what you hear, you're going to forget. Everything I tell you tonight, people, you're going to forget in 2 weeks. But if you pay attention and you contribute and you raise your hand or you answer some of the questions, you're going to remember some of these things. You all know what a BSS is, right? Blizzard, storm, scenario. Okay, which we get in the Northeast all the time, and that can occur. And one example of which I told you is an unconscious hypoglycemic patient. So that is the blizzard storm. So the next 3 suggestions can reduce the occurrence of a medical emergency in your office. Number 1, taking a great history. And I don't mean the history that you get from the society and your standard medical history. Recording basic vital signs, super important. Giving great local and testing it will reduce medical emergencies because pain and unexpected fear can trigger a person who's hypertensive can have a hypertensive crisis. A person who's nervous could hyperventilate. Of course, a person could go into syncope, but people that are asthmatic can have asthmatic attacks. People that are epileptic can have epileptic attacks. And people that have angina, of course, could have an angina attack. So that's obvious. Just looking at that, people feel like that, okay? They can have anything from hypertension to hyperventilation to asthma to angina to an anxiety attack to seizures to syncope. Because we see it as a syringe, but they don't. To them, this is terror. And we have to get ourselves into their framework and their head into their thinking. We should all change on our history page the things about heart murmurs, add questions relating to diabetes, because now diabetes is a coronary artery disease equivalent, especially if they're over 6.5, which is almost every diabetic. I know one person who happens to be a dentist who's under 6.5. He has a trainer come to his house 3 times a week, and he goes to the gym the other 4 days. And with that, and watching everything he eats, he's at 6.4. People that are taking medications for osteoporosis, we have to know about drugs like Zometa and Iridia because of the potential for them having osteonecrosis, bisphosphonate osteonecrosis. So there was a book written back in 2005 by Malcolm Gladwell called Blink. I'm sure some of you have read that and heard about it. I saw him actually speak at the 92nd Street Y in Manhattan, which I go to all the time because I live partly in Manhattan, and it's just a great venue, and we have great speakers there. But he talks about this thing called thin slicing, which is filtering in the very few factors that matter from an overwhelming number of variables. Athletes can do that. All these athletes depicted over here are able to do that. They're able to look at a rink, look at a field, look at an area, and realize where all the people are, and that in a quarter of a second or a half second later, how that's going to change. And they're going to get involved into the middle of the play or the scene and be involved in it. So I'm going to give you an example of it. How many of you like baseball? Are we baseball fans in California? Good, excellent, okay. So there was this play that was done with the New York Yankees against Oakland many years ago. And the Yankees were in the field. The pitcher for the Yankees throws the ball, and the hitter hits the ball into right field for Oakland. And there is a runner on first base. Some of you that know baseball know what I'm talking about, right? Do I see any yeses here? Okay, I see a couple of yeses. And so the ball's hit to right field, and the right fielder catches the ball, and then he throws it to home plate because the runner, whose name is Giambi, is on first base, and he's running from first to second to third, and he's sliding into home base. Okay? We all got the picture? Okay. Now, as the ball is thrown from right field, as it leaves the hand of the right fielder, there's someone in the Yankees that realizes it's not going to make it to home. In fact, it's going to make it about 1/3 of the way from home plate to first base. So who should be the person on the Yankees team that should intercept that ball to then throw it to the catcher to get the guy out who's running the bases? Who do you think might want to catch that ball to intercept it? Who's going to give me any idea? Pitcher is a good choice. Give me another choice. Hold off on that one. You know too much. So pitcher is first choice. Who's second choice? Yeah, second baseman, maybe even first baseman, right? Because it's going to land between home and first. Okay. Why did you say shortstop? Was that a guess, or do you know too much? Oh, you know too much. Okay, all right, okay. So the least person you'd expect to do it would be the person who's shortstop, because he's in a different zip code over here. So at this very moment, when the ball leaves the right fielder's hand, I think those three people are texting, because the only person that responds is the shortstop, whose name is Derek Jeter. Watch what happens. It's going to happen really fast, okay? Then it's going to happen in slow motion so you can see. Now it's going to happen in slow motion. That's Derek Jeter, and his shortstop throws it to the catcher, and guess what? He's out. Do you know how many times that happened before this, and how many times that has happened after this play? Never. 0. So what I'm making a point here is that he thin sliced. He was able to know from the overwhelming number of variables the speed and the height of the trajectory of that ball as it left the hand of the right fielder. He knew in a nanosecond. He did what's called an OODA. OODA is not a character in Star Wars. OODA stands for observe, orient, decide, and take action. Observe, orient, decide, and take action. The work of a person named John Boyd. John Boyd worked. He was actually retired. He was a Navy, Air Force person. He was retired when the Gulf War began. They got him out of retirement, and he single-handedly devised and developed the entire strategy in the Gulf War, of which we were over with in a few days. He was brilliant. He knew how we respond in times of stress, what we do, and his methods in OODA, O-O-D, it's called the OODA loop, O-O-D-A loop. And if you want to look this up in Wikipedia or read about John Boyd, it's a fascinating story. It's how we respond in the times of stress, like we in dealing with a medical emergency. And we'll talk about that a little bit later. So what Derek Jeter did is he thin sliced the situation to know exactly what was going on. What I'm telling you is that we as dentists and hygienists have to do the same with our patients when they walk into the office. We have to look at them, look at the gait at which they use when they're walking. Do they make eye contact or not with us? When we shake their hands, we don't do it to be nice. We do it because it's actually diagnostic. If it's cold and dry, it could be hypothyroid, and if it's sweating and warm, wet and warm, it could be hyperthyroid that you're picking up. So a handshake can be diagnostic. Other things, face and forehead. Is it cold, pale, and sweating, indicating that they're going to faint? Jugular vein distension. When you put the patient back in the chair, 20 degrees, if their jugular vein comes out, especially as they inhale, that's called Kussmaul's sign, and it's an indication of jugular vein distension, meaning possible cardiac issues. Breath sounds during conversation. If the person is asthmatic and they have emotional asthma, if all of a sudden they, like that in a high-pitched sound, they're going into an asthma attack. So talking to the patient, looking at the patient, all these things are important that we can thin slice them before they actually sit down. Other things you could do, that's the jugular vein coming out. Examine 20 paces. You can look at a person as they walk in the room. Look at their eyes. Their eyes can tell you so much about them. Are they jaundiced? Do they have blue sclera? Blue sclera, you remember from dental school, what's that an indication of? Remember osteogenesis imperfecta from our dental boards? Well, I will tell you that that indicates other things as well. What about if they're barrel-chested, indicating possible COPD or osteoporosis? But blue sclera could also indicate hypothyroidism. Remember, we talked about peripheral numbness with hypothyroidism before. Osteogenesis imperfecta, I'll show you why that's number 27 in a second. Even conjunctival melanoma. You could diagnose a person having melanoma from a little blue spot on their eye. In fact, I know of a person that had that diagnosed exactly from that exam in a dental office and saved their lives. So now we know 3 things with hypothyroidism, and you're going to say, well, why are you focusing on this? This isn't one that you'd really hear about in other lectures. Cold and dry handshake, peripheral numbness, and blue sclera. Because people with hypothyroidism, and there's an article that I cite in your questions. You have questions at the end of this, or online. There's 10 questions of questions and answers. Everyone here gets these questions too. And the last one cites this article that you could look at. But people with hypothyroid, subclinical level and clinical level, are at increased risk of hemorrhage. So when you have your patients that are hypothyroid or subclinical hypothyroid, you take out a tooth on this person, and they go home at night, and they're the ones that call you at 10, 11 o'clock, and they say, Doc, the bleeding isn't stopping. Those are the ones that are going to have a problem. So when you have people that are hypothyroid, you want to think about that. They have abnormalities in their Willebrand factors and their factors 8 and 9 deficiencies, and these are the people that are going to have problems. Don't do like full mouth extractions on your hypothyroid patients. Little pearl, little something to remember. So when I was a resident back in 78, 79, in my general practice residency, I was very fortunate to be taught by a great pathologist by the name of Leon Eisenbud, and he gave the residents 66 clinical correlates, and this is all available to you. When you have these clinical situations on the left, it most likely is that the patient has these medical conditions on the right. So again, this is like the 4th thing I'll be happy to send to you. This is a recent one, and that is people that have bilateral Fordyce granules buccal mucosa are people with high, potentially extremely high cholesterol levels, and you could actually save their life. So second time, we're going to go into Physiology 101. This is something I think you should all have. I hope to give out 4 of them today if you answer the questions. And how are we doing? Okay. Pulse oximeter. And a pulse oximeter is something you can have in your office that tells you the saturation of oxygen in the person and tells you what their pulse is. Oxygen saturation is important because under 93 is a problem. Normal, 95, 96, 97, 98, 99, up to 100. But under 93, you might want to consider giving the person oxygen. If a person has high 80s, especially if they're pregnant, a pregnant female in the high 80s, you may have just diagnosed a pulmonary embolism. People die of pulmonary embolisms in the United States, 250,000 plus people a year. The number of people that die from cardiac arrest, 350,000 to 400,000. Pulmonary embolism is up there as another major cause. You can pick that up with high 80s pulse oximetry, especially in a pregnant female, because that's consistent with being pregnant as well. But pulse oximetry is important. I suggest that you all have one of these in your office, and you'll see why in a few minutes, because it gives us a number called a rate pressure product, which I'll talk about in a little bit. Having a glucometer is important. A1C testing, this one is made from CVS. And having a blood pressure unit. You don't have to take the blood pressures the old way. You could use an automatic blood pressure cuff. They're just as accurate. This company happens to make another one. I don't work for the company. I don't get anything for this. I'm just telling you that it's pretty accurate and it's a good make. But the problem with this is that it takes the pulse at the moment that you have it on the patient. So you get a systolic, you get a diastolic, and you get a pulse, but the pulse is not static. The pulse is static, it is not dynamic. It's not changing as the pulse is changing in the patient. The pulse oximeter changes as it changes in the patient. It is a dynamic. So this is important, something called the rate pressure product. And I'll explain what this is. It is very simply, I'm sorry, we'll go back. No, what it is the systolic blood pressure times the pulse. And when you multiply the two, you have a number. And what this indicates is that when it is higher than 13 to 15,000, when it's higher than 13 to 15,000, it suggests the compromisability of the myocardial coronary vessels to give oxygen to the heart. 13 to 15,000 if you multiply systolic blood pressure times pulse. Now, again, I told you we have to go back to Physiology 101. So let's assume we're giving local to our patient and they're comfortable, they're relaxed, which they're really not when you're giving them local, but let's assume they are, and their pulse is 60. Okay, a 60 pulse, you're giving them local. This is going to be the pulse rate as it's going to go up, because believe me, no one gets local anesthesia when they feel the pinch of the needle and their pulse goes down. It always goes up. So we're going to take systole and we're going to take diastole. The lub-dub, contraction, relaxation of the heart, systole and diastole. Each we're going to give a certain time frame, which is a half second. So 0.5 seconds in systole, 0.5 seconds in diastole. Lub-dub, lub-dub, lub-dub equal. That's at a pulse of 60. Now you give the person local. What's happening? The pulse is going to 70, maybe 80. What's happening when the proportion of time that the heart is in systole and diastole is it's changing. It's changing at the expense of diastole. So instead of being a half second and a half second, as the pulse goes up, now it goes into 0.6 systole, 0.4 diastole. Are we all on the same page? Now we're going to go to 100, because now when you're giving that local, it's at 100. And I can tell you that all you got to do is put a pulse oximeter on someone and you'll see that they're at 100 as you're giving them local. Now systole is at 0.7 and diastole is at 0.3. It's almost twice the time frame in systole as it is in diastole. So you might say, big deal, but I'll tell you what the problem is. The only time that the myocardium is getting oxygen through the coronary vessels is during diastole. Okay, so now process what you just learned. If the diastole is the only time your heart is getting oxygen and the pulse is going up, and let's assume that person has angina, okay? So now the pulse is going up to 100. They're only 0.3 now, and I'm exaggerating the numbers, but just to make the point, it's considerably less of the percentage of time in systole diastole. It goes lower in diastole. You're giving them an angina attack. Now, what air are they breathing when this is occurring? They're breathing the room. What percentage of oxygen is in the room? Who's going to tell me? About 20%, exactly right. Well, what about if you had this person who has angina and you're giving them that local and that pulse is going 60, 70, 80, 90, 100, but you gave that person 100% oxygen before you gave them the local. Now, even though the percentage of diastole, because you're not going to change their pulse not going up, even though their pulse now is going up to 100, they're breathing 4 or 5 times the oxygen that they were breathing without having the supplemental oxygen. Are they going to have pain in their chest? Absolutely not. So there's a simple thing you can do to prevent a medical emergency, giving a person who's got angina, especially if they say they take their nitroglycerin twice a day, which is unusual, but they might tell you that. Just give them 100% oxygen before you give them local, and you'll prevent the medical emergency. Give people oxygen also that have a 93 and under pulse oximetry. This is the rate pulse pressure product, some statistics on it on the bottom. It correlates also now with high rate pulse pressure product of over 13 to 15,000 with also a BMI over 30. So a person who's over 30 and has a high rate pulse product to give them oxygen. What's interesting is red blood cells give up 30% of their oxygen to peripheral muscle tissue, but when it comes to the myocardium, red blood cells give up 60% of their oxygen. So they're very sensitive. The myocardial muscle tissue is very sensitive to a lack of oxygen, which is why it's so important. So when would you give oxygen? Well, one example would be people with angina. Another would be rate pressure product over 13 to 15,000. Oxygen saturation below 93. History of congestive heart failure with jugular vein distension and exertional dyspnea, meaning they can't walk up a flight of stairs. Okay, you could give them oxygen. Asthma, treated with steroids and anticholinergic meds. Patients with a history of seizures not responsible to meds. Oxygen will lower the threshold for a seizure to occur. How many of you in this room have seen patients or people have a seizure? By a show of hands. Usually I get about 50%. Okay, it's about a third here, but I usually get about 50%. If you have a patient have a seizure in your office, as soon as the seizure is over, give them oxygen, because that'll raise the threshold for them having a second seizure, and that's very critical to know. Macho man, 16 to 30-year-old, first time he's in your office, first time he's in a dental office. He comes in and you have to take out a lower first molar that's below the gum line, and he says, okay, doc, I'm ready, and he holds the edge of the chair and he says, okay, I'm ready for the local. Is he not going to faint? He's going to faint 100% of the time. So what do? Put him supine, give him 100% oxygen. He can't faint even if he wants to faint. Make sure to let that oxygen get in him for a few minutes before you give him the local. History of an MI in the past 6 months. Technically, you shouldn't be even treating a person who's had a history of a myocardial infarction within 6 months, because the likelihood of a reinfarction in the first 3 months is 30%. From 3 to 5, it's down to 15%, which is a lot higher than it is after 6 months, which goes down to 5% and under. So, but if you have to treat a person as an emergency, giving them oxygen would be helpful. Two new things are, and I just mentioned this, a rate pressure product over 13 to 15,000 and a BMI over 30. And a third trimester of pregnancy in a patient having difficulty breathing. Most people in the third trimester of pregnancy are not in your office having treatment, but if they are, and they're having difficulty breathing, you might consider giving them oxygen. So, all of you know what this little thing is here, right? 4 on the what? Uh-huh. Where did that go? Here we go. Okay, so it's 4 on the floor, exactly. But I'm not going to talk about 4 on the floor that's in the middle of a car. I'm going to talk about the 4 conditions that people might have that would wind up on your floor, okay, going from the waiting room to your operatory. So asthma, angina, epileptic patients, and diabetic patients. These are the 4 that are most likely for that to happen. So for those 4 people, I have developed what I call the conversational history. This is the history that is not what they fill out, because what they fill out is what they want you to know. It's not going to be the important things that you want to know about them that they don't want to tell you, because if they tell you, you might not treat them. So, number 1 question you ask people with these 4 conditions: do you drive? Because people that are diabetic, epileptic, and alcoholic will not drive because they've had their license revoked, and or because they are so severe and have such complications from their diabetes or epilepsy that they can't drive. Do you think any one of those 3 people will tell you that the reason that they're not driving is because of that? Absolutely not. It's the last thing they'll tell you. But if you have an index of suspicion of knowing that the person is diabetic and can't drive, that tells you you have a high index of suspicion that they may have a problem in your office. They're at a higher risk for problems. Can you walk up a flight of stairs or walk 1 block without stopping? Any peripheral numbness? We'll talk about that a little bit later, and as far as DASH, D-A-S-H, we'll discuss that in a little bit. So the diabetic patients, you want to know, did they take their medication? Did they eat? Asthmatic patients, what type is it? Is it environmental? Is it emotional? Do they carry their inhaler with them? And the most important question for any of these 4 on the floor would be, have they been in the hospital for this condition? Because when you have these conditions and you go to the hospital on a regular basis, the level of severity of them is much more involved than if you do not go. For the epileptic patients, you want to know what their aura is. You want to know if they've been to the hospital, how often they have an attack. For the angina patients, how often do they use their nitroglycerin? But again, hospital or not hospital differentiates the ones that are going to be a problem and not. So these are the simple tests we can take in our offices: blood pressures, pulse oximeters, glucometer, and A1C testing. So we're now at about the halfway point, and my question is, do we want to take a 5-minute break, or do we want to go right through? Keep going, right? Okay, that's what I thought you were going to say. I knew you were going to say that. Here we go. So when do you call 911? Well, basically, anytime you feel the need. Remember from Top Gun? Feel the need? So loss of consciousness no more than 10 to 15 seconds. Of those, all of those here that have had patients that have fainted in their office, it's pretty much, well, let me see by a show of hands, who has never seen a patient faint being in a dental office? Okay, so it's usually the same number of people that give IV, about 1 or 2%. So most of you have seen a patient faint. Those of you that saw people faint, which is almost everyone here, how long were they out for? Were they out for 5 seconds, 10, 15, 30, or a minute? Just by a shout out. There's no prizes here. 5 seconds? Do I hear 10? 10? Do I hear 15? Do I hear 30? No, I don't hear 30 at all. I never hear 30. But do I hear 15? Anyone out 15? Questionable, right? Well, here's the interesting news. Almost always, we come out of a syncope 11 to 12 seconds the most. When you're unconscious for more than 11 to 12 seconds, it's usually something more severe than a simple syncope. But what's the one thing you have to do for a person who's in syncope? So put them supine, okay? Make sure that that person goes supine, head tilt, chin lift, give them oxygen. In 10 to 12 seconds, they're going to be fine. When they're not fine at 10 to 12 seconds, then we're going to talk about what you can use, and we'll talk about that when I get to the drug kit. You call 911 with any use of epinephrine, and I don't mean epinephrine in the local, okay? So any use of epinephrine, meaning for an asthma attack or an anaphylactic reaction. Asthma attack not relieved by 2 inhalations. An angina attack not relieved by 2 treatments of nitro. An angina attack that then is relieved but then comes back, because that's now becoming an MI. Chest pain of unknown origin, loss of consciousness. Also, what about stroke? The mnemonic for a stroke is, the fast FAST, and I'll show you what that is. So we have, well, before we do that, hypertension and hypotension. If a person has excessive hypertension or hypotension, that's reason to call 911. However, you don't know if they have excessive hypo or hypertension unless you have a baseline. That's why it's so important for you to have a blood pressure when you start the procedure. Because if they go up a lot or down a lot, is reason to call 911 or not.
This is Houston. Say again, please.
Houston, we have a problem. We have a main bus being undervolt.
The reason I show this is because they, the astronauts, when they had that emergency on Apollo 13, they rehearsed it 300 times and knew exactly what to do. Not like us, if you haven't rehearsed and didn't do your mock emergencies. And by the way, James Lovell never said what he said in Apollo 13. That was Ron Howard's poetic license to make you get tickets to go watch the movie. What James Lovell really said was, hey, Houston, comma, we've had a problem here. A lot different than what it shows in the movie, right? But that's Hollywood and makes movies. So UDA, you all know what that is. John Boyd, observe, orient, decide, and take action. And James Lovell did that in a nanosecond, just like Derek Jeter did it when he did the thin slicing and threw that and got that ball and threw it to home plate. So thin slicing, 4 on the floor, things like that you could use in order to help lessen the likelihood of medical emergencies. Posted 911, this is something that I came up with. So you have a person who is in your office, especially people with angina or asthma, and they all of a sudden don't look too good, okay? And you look at them and you say, you know, you don't look too good. I think I'm gonna call 911. Good idea or not a good idea from the patient's point of view? They may get worse because they're actually not only nervous, but they're nervous that you don't know what to do about it. So idea, you could just write on a Post-it, get a Post-it, write 55-year-old female, severe chest pain, or male, or whatever it is, and give it to your assistant to bring to the front and have 911 called. When they get in, when the EMTs get into the office, it is not likely that your patient, if they're getting worse, is going to be upset. But they will tell you, no, I'm fine, always when you ask them, should you call? So that's what I call the Post-it 911, and then when they come in later, everything can be better. Males versus females, when it comes to this, we're really bad. Women, you call 911 at the moment you have a problem. Guys, we wait, and we die. And it's a problem because we wait too long. So, I mean, you look at nursing homes and like there's 300 women and 1 guy. There's a reason for that, okay? So I'm just letting you know. You know, there's a nursing home in New York City, one of the most expensive ones in the world, where you actually, it's on the Upper East Side, right near Hospital for Special Surgery, and I'm not going to tell you the name of it, and they actually have happy hour there from 4 o'clock to 8 o'clock, where the children of the people in the nursing home go there, free drinks, 4 to 8 o'clock, and then they go see their parents and grandparents upstairs. Pretty interesting method for getting people in a nursing home, especially in the borough of Manhattan. So the 3 UNs, okay? I learned this from someone in Canada, and this is the 3 UNs. When you have a medical emergency in your office, you don't want the you don't want the C team coming of the EMTs or the B team. You want only the A team. The A team has been doing it for 10, 15 years. The B team, a year. The C team, first run, okay? So you tell them you have an unresponsive, unconscious, unable to find a pulse in your patient, and you get what? You get the A team. So remember the 3 UNs, unresponsive, unconscious, unable, because when they hear that, they're not sending the people that just started out that day. By failing to prepare, you're preparing to fail. Ben Franklin, give me 6 hours to chop down a tree, and I will spend the first 4 hours sharpening the axe. Abraham Lincoln. So what we're all doing here tonight is sharpening the axe, and I thank you for coming here. And this is about the point I would take a break, but we're going to go right through it. Okay, so this is what the Marines say, proper preparation prevents poor performance. There's actually another P in there, which I'm not going to put in. But you have to be prepared. More than like John Lennon in Imagine. More than like Doris Day in the movie. Who's going to tell me the name of the movie?
Whatever will be, will be.
The man who knew too much. But you have to be more like Rocky and realize what's going to happen and to deal with it. There are more medical emergencies happening today and occurring today because people are living longer. And as a result, here we go. As a result, you're finding people that are alive today that were not alive just a few years ago. People on Plavix, people with portable oxygen, people coming in with implanted defibrillators. They weren't around 20, 30 years ago. So more people are coming in. You're getting a much higher percentage of the population older. And as that changes in the next 25 years, the number of elderly people will double. So significant issue. 1/3 of the population will soon be pre-diabetic. Actually, half in probably 20 years will be pre-diabetic. Incidence of asthma in children and young adults is increasing, over a 30% increase in the last 20 years. Alarming increase in the number of type 2 diabetes in children and adolescents, with 1/3 of children as overweight and 17% being obese. Young people, both these groups are likely to experience serious health issues later in life. So this is going to be a problem. There'll be more medical emergencies because of this. So I don't know about you. When I go to my doctor's office, I go and they approach me at the front desk and they say, Dr. Pompe, could you please come up? And I do, and they ask me this important question, and I'm ready for the real important one. It never really occurs, but they say to me, has there been a change in fill in the blank? No, that's what I want to hear. There has been a change in what? My insurance, right. That's what they want to know. Has there been but it really should be, has there been any change in your medical history since we've seen you last? And that is called what I call DASH. Dash the ABCs. Must ask questions every time. So DASH with a dash in between each letter. D stands for any new drugs. A stands for any new allergies. S stands for any new surgeries. And H stands for any new hospitalizations. Every patient should be dashed every time you see them. If you see them on Monday and you're going to do the procedure on Tuesday, you dash them on Tuesday, because Monday night they may have had any of these 4 things occur. I will tell you that if every patient had DASH every time they were seen, there would be a lot more people alive that are not after going to dental offices and dying because of not asking the right questions. This is the ABCs. And I also would tell you that if the person has a positive answer to any of these, put a check mark next to it, and that patient does not get a tray set up in the office. Now, of course, you got to approve this with your doctors and your staff in your offices, but I did this. And there would be no tray set up until the doctor would say and question the patient about why that check is there, and then the tray would be set up. So it's sort of like an internal fail-safe mechanism that you could use. The ABCs, by the way, if you want to go into the further part, are they on an aspirin regimen or sensitive to it? Any bleeding disorders or history? Is there any history of chest pain, and is there any shortness of breath? You'd be amazed how many people come to our office that have both chest pain and shortness of breath and do not tell us about it. When do these emergencies occur? Almost always when you're giving local or right after the local. So right after giving local is not the time to make the phone call, return the phone call the stockbroker, call your wife, call your husband. It's right after that time that the people can faint. So you have to be very careful during that time. 55% of syncopes occur at that time. Almost always it occurs during an extraction or during a root canal. So those 2 procedures overwhelmingly cause people to have syncope. We'll talk much more about syncope later, but this is the percentage of syncope. Now, I can tell you that I'm finding that the second biggest thing now is becoming hypoglycemic emergencies. So in the old days, they talked about mild allergic reactions, angina, postural hypertension, seizures. I think that hypoglycemic situations are now coming way up to the top, and I'd like your help in doing this, because I can send you a questionnaire and you could just check and give me the number of times you've had different emergencies, and that's going into an article that I want to publish in about a year. I have over 300 or 400 responses at this time. I want to get about 500 to 1,000 before I publish that. So this can change this whole scenario significantly. I believe that's happening. Different types of emergencies fall into inconveniences, urgencies, and true medical crisis. The good news is very few of them are real true medical crisis, even though to us we think some of these are real big emergencies. Loss of consciousness, remember, up to 12 seconds, almost always benign. Once it hits 15 seconds and more is when you run into serious problems, and we'll talk about what they are. So placing the drugs where you want them, and the color coding is in itself a test for your drug knowledge. I believe you could go to like Home Depot and go to the paint department, get one of these kits for about $14.98. I like this because you can actually see through it. So when you have a medical emergency, you know, you're so nervous. When you open up the kit, you're like this. The drug's going to fall on the floor, a scenario that's happened, I've heard of many times. So seeing where the drugs are in the kit is important. And this is the different routes of administration that we can have. We're not going to go through all these. We go through this more in the full-day course. But obviously, topical administration of a drug in an emergency doesn't work, and PO works, but only partially. What do I mean when I say that? We do give the drug nitroglycerin as a pill, but it's sublingual, so it's also being absorbed through the mucosa. And we also give the drug aspirin in an emergency. Why do we give the drug aspirin in an emergency? For what condition? For a myocardial infarction. Okay, so a person's having a myocardial infarction, you want to give them aspirin, but do you just tell them to swallow it? No, you tell them to what? to chew it and then swallow it. Okay. And what I'm going to suggest that you do is you use non-enteric-coated and you use 4 baby aspirin as opposed to a big aspirin, because how many of you have chewed a big aspirin and tried to swallow it? The person has enough problems dealing with the pain of an MI. They don't need additional problems. So 4 baby aspirins is the kind way to deal with that, and make sure it's not enteric-coated. So this is my top 10 list. The amount of drugs that go in intravenously, none. IN, intranasally, the amount of drugs are 4 in the kit: midazolam, glucagon, Narcan, and Flumazenil. Now, we don't go into all of this 100% right now, but I will tell you that this is the drug to use for a seizure. I will tell you a little bit more about it later. Glucagon, I've already mentioned to you, is the drug to use 1 cc of it intranasal for the unconscious person who is diabetic. So they're unconscious, diabetic. No one is getting to your office because there's an environmental problem for an hour and a half. All you got to do is give them 1 cc. But what I didn't tell you, and this is going to be my second prize, and I'm going to upgrade this because this is going to be a hard question. Let's see who gets it. I'll give you a glucometer for this. Is that you don't give 1 cc to one side. What you do is you give a half cc to one side and a half cc to the other side. Why? Very good. Excellent. Very, very good. You know, I get the most complicated answers for that question, and it's basically you got to just think of the basics, and that's exactly right. What happens if one side is blocked? They're not going to get it in. That means you get 1 cc into the blocked side, nothing happens. If one side is blocked and you do 50 and 50, you at least have a half a cc, in which can get them up about 125 milligrams. The likelihood is both sides are open, but it's that one time. Okay, so you have to be careful. Narcan, of course, you know we're all using in our drug kits. I've had this for the last 7 to 10 years recommending it, but now it's finally included in most drug kits. And Flumazenil is the drug to use if you give too much midazolam, which is the drug you need for a seizure. So a person having a status epilepticus, meaning the seizure is going on for more than 5 minutes, or they have a seizure and it ends and then boom, it starts up right again. But it's also a blizzard storm scenario or a severe weather situation where you're getting nobody coming. You can give them the midazolam, 5 milligrams, 5 milligrams, total of 10 milligrams. It's being used by many EMT programs across the country now, and that is the drug. Or you can give it IM, but you could also give it intranasally. So pump aerosol is your albuterol, which is your pump for asthma, and nitroglycerin also can be used as a pump. But the nitroglycerin, I will tell you, as a pump, is about $150, and it is totally useless. Why? Because how many in this room have used nitroglycerin for an angina attack for their patients in the last 5 years? By a show of hands. Right, none of you. Okay? So why are you spending $150 every year when you're never going to use it? Buy the pills. The pills are only $15.99. Okay, and not the spray. The advantage of the spray, by the way, is there is one advantage. After the first spray, it's good for a full year or a year and a half. Once you open the pills and give 1 pill to a patient, or 2 or 3, how long before those pills are inactive? Who's going to tell me? A few weeks, like 6 weeks, 6 to 8 weeks. So what happens? What do? You order the pills as soon as you use it, if you ever use it. How do you not run out of your drugs and have them expire? Because I can tell you right now, almost everyone here has an expired drug in their drug emergency kit. No? I'm very impressed, but unfortunately many of you do. What you do is when you set up the kits yourself and you have someone assigned to making the kit, you look at the expiration date, which, by the way, doesn't mean the drug is expired. It means it's 90% active on that date, which doesn't mean you should be using them, but you don't have to send them overnight, Federal Express, one night, because you realize that it's expired. You put in your schedule Mrs. Epinephrine, Mr. Benadryl, Mrs. Albuterol, and double book that patient with another person because obviously they're not showing up, okay? And that way you know that you have to order that drug and put them in for an appointment a month before the drug expires. So you know that you have the drug always active. So put them in your schedule, put them as a person, but double book them, and that's a way to not have your drugs expire. Narcan, this is the atomizer, by the way. This thing that goes on the top, this little triangle, is called an atomizer. And then you need a 3 cc syringe to apply that. Inhalation, nitrous oxide is actually a drug in the emergency kit. How many people know that? Okay, so another drug to use for an MI, in addition to aspirin, is morphine. In fact, the mnemonic is MONA, M-O-N-A. M stands for morphine. O stands for oxygen. N stands for nitroglycerin. A stands for aspirin. So let's take it from the beginning. Morphine. How many people here use morphine? Right, none of us. But how many people here have nitrous oxide in their office? You don't raise your hand, I'm sure most of you. Okay. Nitrous oxide, British intervention here. The British have taught us that 4 liter to 5 liter each of nitrous and oxygen gives as much pain relief as 10 milligrams of morphine without respiratory depression. That's the drug you want to use for a person having a myocardial infarction. Get them on nitrous oxide for the pain and for the oxygen. So now they're on the oxygen. Then you want to give them MON, nitroglycerin, and then aspirin. Now, when do you not want to give nitroglycerin? If the systolic blood pressure is under 90, and if it's a guy that took erectile dysfunction medication within 24 to 48 hours. You got to know that, okay? Aspirin. Do you ask anything about the aspirin? There are people that are allergic to aspirin. Now they're having an MI. You give them an aspirin, and now you're going to deal with an allergic reaction as well. Don't give aspirin if they're allergic to aspirin. So that's the other reason not to give it, okay? Allergy to aspirin. Almost no one's going to be allergic to nitroglycerin. Oxygen tank. This is the first drug in the kid. You should have an E-cylinder. What is an E-cylinder? It's when you have to bring the oxygen to the patient, not the patient to the oxygen. So if the person falls down in the waiting room and you're not going to pick them up and bring them into your operatory, you want to get oxygen to them, you have to have an E-tank cylinder. What do these cost? About $300. Where do you get them? You should get them through the people that supply your oxygen and nitrous tanks to your office. That'll be the most cost-effective way of getting it. And you also need it to actually get a nebulizer to work. All of you have albuterol pumps in your drug emergency kit, right? But the nebulizer that I have here, which has a packet of albuterol in it, is as effective, if not more effective, because when a person is having an asthmatic attack for the first time and they don't get it into their lungs. They usually get it into the back of their soft palate, especially if it's a child. They're not, how many of you know kids or yourself that have asthma? In the beginning, using an albuterol pump is not the easiest thing to master. And if it's the first time having the attack, this is going to be as effective, if not more effective. But you can't get this to activate and nebulize the albuterol unless it's over 10-liter flow. How do you get over a 10-liter flow? Have an E-tank cylinder. So almost every drug I'm going to tell you about has multiple usages. Oxygen, to bring the oxygen to the patient in the waiting room, and to activate a nebulizer, which I have a few to give out today. Epinephrine. This requires a little bit of cerebral thought, okay? So bear with me here. Epinephrine, the EpiPen comes in 0.3, okay? 0.3 of 1 to 1,000. That's an EpiPen. All right, you all know how much these cost too, right? Okay. When we're all done with the lecture today, hang in there, and I'm going to tell you about a way that you can get these things for a very reasonable price. EpiPens, 0.3, 1 to 1,000. Epi Juniors are half, 0.15 milligrams, 1/2 the dose. You all should have Epi Juniors in your office as well, and I'm going to tell you why now. Epi Junior, let's assume we have a person having an asthmatic attack, okay? Asthmatic attack, you're giving them what? The albuterol, 2 pumps, you're sitting them up, you're giving them oxygen, they're turning blue. In fact, I could tell you about a story of a friend of mine that had this happen to him and sat the patient up, gave them 100% oxygen, albuterol pump number 1. 4 minutes later, pump number 2, 2 squirts, by the way. So 2, he inhaled it, 2, he inhaled it. It's now a few minutes into this. He's turning blue. He did not call 911, and what happens to him is he freezes, as we all do. He's frozen. He's like in a state of panic, terror, but he remembers one thing. Who's going to tell me the color of the card for a respiratory or breathing problem? Right, you all know it's blue. What did he remember? Blue. He was frozen, he was panicked, but he just saw blue. He got the blue card, he went down the list, he saw what you do after albuterol's not working. What is it? Give an EpiPen. But before you give an EpiPen to a person and inject it, which you inject through the clothes, you have to tell them something. You have to tell them before you give it, you're going to feel as if your heart is going to burst out of your chest. Then you give them the EpiPen. Because if you give them the EpiPen without telling them that, and then they feel that, they're going to have an anxiety attack. Do you really need to have an asthma attack with an anxiety attack? No, you don't. So you tell them that. So now let's assume that the person who's having this asthma attack is 90 years old and weighs 80 pounds, maybe 90 pounds. Mrs. Jones, who comes in, she's 90 years old, she's a little person, and she's having the asthma attack. Are you going to give her an EpiPen? 0.3, 1 to 1,000? Well, you might consider to do something else. Give her an Epi Junior. Because her weight and her size is like she's a child. Okay, so you give her an Epi Junior, and you wait like 5 minutes to see if she does better. No, if she's not doing better immediately, you give her the Epi Junior on the other side. Now, why am I giving one on one side and one on the other? Remember what I told you about alpha receptors? What does alpha do when epinephrine gets in? Causes what? Vasoconstriction. So if you put the second EpiPen into the same spot, does it get in? No, so you got to go to the other side. Okay, so now you know use of an Epi Junior that's outside the box. Second reason for the use of an Epi Junior, and this is a little bit controversial what I'm going to tell you, but again, what we learned from our British colleagues, okay, third very important thing, if you're a big person like me, over 200 pounds, and I'm having an anaphylactic reaction, the entire country of England now doesn't use 0.3 for an anaphylactic reaction, they use 0.5. Okay, so I'm the one having the anaphylactic reaction. I would benefit from having 0.5, but can we give 0.5 with these solutions? How do we do it? We give a 0.3 and we give an Epi Junior. Epi Junior is 0.15. So we're almost at 0.5. It's good enough. Okay, so I can stay alive now for 10 minutes because I have almost 0.5. You give it every 5 to 7 minutes in an anaphylactic reaction. Okay, second reason to use an Epi Junior. Third reason to use an Epi Junior. How many of you had EMTs get to your office for a real emergency and they're there at exactly 10 to 12 minutes? Well, maybe they get there at 13 or 14 minutes, or maybe 15 minutes. Well, if it's an anaphylactic reaction and you give it at time 0 and you get to 5 to 7 minutes, and then you give the second dose of your epinephrine, and now you're at 10 minutes, but there's no ambulance. Okay, so you've used EpiPen 1, EpiPen 2, now what do you got? You have 2 Epi Juniors. What do? You give them both at the same time for the third dose, and now when they're there at 15 minutes, you have a patient who's alive, as opposed to one who'd been dead for 5 minutes because you didn't have the third dose. Okay, so that's the third use of an Epi Junior, and by the way, there's this other need for an Epi Junior, and what do you think it is? A child. Okay, 33 to 66 pounds, all right, is a child. So multiple uses for Epi Junior that are outside the box. Oxygen, this is your E-tank cylinder, which you use to attach to a nebulizer, which I have a few left, and that'll get it going. This is the order of things to use for an anaphylactic reaction. Respiratory distress, put them upright. If cardiovascular distress, anytime cardiovascular distress, you're going supine. Supine, by putting a person supine, you get 2 liters of fluid to get into the person. How do you die in an anaphylactic reaction? It's peripheral vasodilation. Everything just gets dilated out and you go into cardiogenic shock. So getting the person supine who's having an anaphylactic reaction will help that initially. Oxygen to start, epinephrine 0.3 in an adult, but you see what I wrote here? Up to 0.5. No dose in an anaphylactic reaction is 0.01 milligrams per kilogram. You could even give more than 0.5, but we're not going to, this is emergency room medicine. We'll leave it at 0.5 as the max you can give, and it's not even being done in most parts of the country. It will be done in 5 years, but right now it's not. In England, by the way, they use 0.5 even for children. 0.5 level even for children. So, but I believe that we'll get there. I always thought that, by the way, in New York, we followed everything that was done in California because you guys always led the way as far as continuing education. We didn't even know what continuing education was in the late 60s, early 70s. But I am surprised that you don't have AEDs as mandatory. I think you will in the next few years, with 28 states being mandatory. I'm sure that and the fact that 90% of you have them is so good. Because I go to some states that it's not required, and 10% of them have AEDs. So there's a big positive in your column for having that. So that's what an EpiPen looks like. The Mylan company was charging, how much for an EpiPen? $600 and something. Okay, Matt and Martin, could we go off for a second? Yeah, we'll take a break. Let's take a break, okay? But I want to go offline. Tell me when we're offline. We're off? Okay, so, because I don't want to tell you this with being online, okay? So Mylan Company was charging 600 plus, right? But then they had a lot of problems with Congress, and you know what happened? They were forced to make a generic. CVS Pharmacy is the only pharmacy, I don't know why other pharmacies don't do this, but CVS Pharmacy, if you have insurance that is not Medicare or Medicaid, and you or someone in your family has an allergy to something, you have 100% right to ask your physician to give you a prescription for an EpiPen. Anyone with an allergy, how do you know the next time you have it, it's not going to be anaphylactic? Anyone with an allergy should be able to have an EpiPen. It's a basic right that we all should have. Any doctor will give you an EpiPen if you have an allergy. So you or someone in your family has an allergy. Doctor, can I have an EpiPen prescription? You go to CVS Pharmacy, and you say to them, you give your insurance card, again, not Medicare or Medicaid, and you say to them, can I have a coupon? Because CVS Pharmacy only will give you a coupon for $100 towards your EpiPen. The EpiPen that you get at CVS Pharmacy costs $110. You've just spent $10 for your EpiPen, but I forgot to tell you, per prescription from your physician for an EpiPen, you get 4 EpiPens. So now you have 4 EpiPens for $10, each one $2.50. Is that a little bit better than spending $250? Okay, did you all pay for did you pay for this course? Did you all have this paid for now 10 times over? I want you to do this for the next 20 years of practice, and you're going to go on a cruise, and you'll send me a letter from, Hawaii or Europe that you're enjoying your cruise. Now, if you don't have allergies, you're not going to, that's the way to do it. And I'm saying one of the 4 that you get is going to work its way somewhere into your emergency kit. If you don't have an allergy, you can't do this, but I'm telling you that you could do it. No, well, okay, technically, yes. As a dentist, you could prescribe an EpiPen. That's number 1, but many pharmacists will give you trouble with that. And number 2, you can't prescribe for office use anymore. At least you can't in New York State. Used to be 20, 30 years ago, you'd write office use and you could prescribe this. You can't. Now you're at the mercy of the companies, and it's very, very costly. Okay, that's EpiPen. Oh, by the way, as long as we're on this, finances, you know Narcan? This is an intranasal administration of a drug that comes in the intranasal, okay? If you go to Rite Aid Pharmacy only, not CVS, and you go to Rite Aid and you say, I have the need to have Narcan because I may have someone that may need this, that's all you have to do. They will give you this for free. So I did it, and I tried it, and I went there, I said, I have need for this, and I got this for free. So there's no charge. Okay, I think we can go back on. Any questions before I do that? Questions about it? All right, or at the end, I'll be here at 9 o'clock and I'm not going anywhere. Okay, so we're going back on. So EpiPen Mylan Company, they've been forced now to make a generic, which is half the price. When you use an EpiPen, remember I told you it goes into this area. This is called the vastus lateralis, the outside of the thigh. You have to take the top of the EpiPen off. This is the part that has the needle that injects. It comes out over here. This needle will not come out unless you take the top off. The EpiPen that you get, which is called an adrenal click, this one, this is orange. Okay, so the top is either orange or blue. Whatever the top is has to be removed before the needle will come out on the bottom. And when you inject it, you hold it for 5 seconds. 5, 4, 3, 2, 1 to make sure the epinephrine gets in. Every 5 to 7 minutes in an anaphylactic reaction, you have to re-give it. And there's your Epi Junior. Okay, so how do you know when a person is having an anaphylactic reaction versus a really bad allergy? This is very important because many people die from anaphylactic reactions, and the EpiPen is right next to them. And the person, to give them the EpiPen, doesn't because they're afraid. And they die. So how do you differentiate an allergy from an anaphylactic reaction? Allergies, you know, are what? Wheals, itchy, runny eyes, runny nose, swollen lips, swollen tongue, difficulty. Well, okay, leave it at that. Okay, that's a severe allergy. And the more severe it is, the more they need Benadryl. Okay, I am Benadryl if it's really bad. But once it changes into the next level, that's when you need epinephrine. And what is that? When your blood pressure goes below 90 systolic, that's number 1. And number 2, when your voice changes to the point that you hear them in laryngospasm. So all of a sudden they're going to, like that. And or when you get below 90 systolic, guess what happens to your consciousness? You're going to be out. So what is the thing to do when a person's having an allergic reaction, meaning the wheals and the runny nose and the runny nose and eyes and lips swollen? You talk to them. You have engagement in conversation, and you don't stop talking to them. And you tell them to tell you about everything in their life, because as soon as they stop talking, their blood pressure went below 90 systolic. And what are you doing? giving them the epinephrine. If they're talking to you and all of a sudden you hear a high-pitched sound, that's a laryngospasm, you're giving them the epinephrine. So those are your indicators. There are two more, by the way, incontinence and severe abdominal pain. Okay? And combined with what we're talking about. So these are gastrointestinal pain. So, and in children, it's less than 30% of their original blood pressure. So it's not necessarily below 90 systolic, it's less than 30% of their original blood pressure. So these are them, persistent cramps, abdominal cramps, and incontinence. This is the article that talks about this. If you want to look up an article that goes into this in depth and detail, it's significant. It's like 60 pages long. You'll know everything about anaphylactic reactions. You lose 1/3 to 1/2 the volume of your body to edema. That's why you want to put the patient supine. The effect of placing supine is equal to putting 2 units into the person's body. So, this.
Proctor. Are you all right?
Fine. And you?
Land the plane as soon as possible.
Ah, Mexico is such a land of contrasts. Oh, no!
Okay, so it's funny, but the point I'm making is that when you hear a person with that high-pitched sound, you're giving what? Okay, so you know now that the indications for giving it. Okay, let's go back to our spirits of ammonia. Remember I mentioned before about that almost no one here saw a person unconscious for 15 seconds? Well, if you have a person who's out for 15 seconds and they're supine and you're giving them oxygen and you did head tilt and chin lift and they're still out, that's when I tell you to use spirits, not at the first second that they go unconscious, which means no one in this room will have ever used spirits. Okay, but when you do use the spirits and it's 15 seconds, and this is the response. You ready? You crush it 10 to 12 inches away, and this is the response. Did you see the response? No response. First thing you're going to think about, especially let's say it's overweight, 60, diabetic. No response. 60 means 60-year-old. Cardiac arrest. That's your first rule out until proven otherwise, because there's no response. Now, at 20 seconds, what are you doing? Get the AED. That's the number one thing to do in a cardiac arrest. You may have that AED in that person in 30 seconds. Likelihood of survival, 80, 90%. If you dilly-dally and look for a pulse and look for breathing and go through the whole routine, it may be a minute or two before you make that decision to get the AED. Quick diagnostic use of the spirits of ammonia. What happens if the response is this? Oh, by the way, most likely the response is going to be this. Okay? And it's going to be syncope and they're going to come out of it. Okay, but what happens if the response is this? Crush, and this is the response. Okay? Just a little bit of movement. Stroke, hypoglycemia, anemia, dehydration, adrenal insufficiency, all of these are possible rule-outs. So the use of the spirits of ammonia is not at the first sign of a person going unconscious, but at 15 seconds, which is almost never, to rule out, A, your cardiac arrest versus your other situations. If you see some sort of a movement, can it be cardiac arrest? No, it cannot be, because at cardiac arrest, they're dead. Okay, so use of spirits. Benadryl elixir. Don't use Benadryl in pill form for a mild allergic reaction. Go to the children's department of your drugstore and get Benadryl elixir. The elixir will get into the system a lot faster than a pill. So elixir is the type that you should have in your drug emergency kit. I haven't seen any kits that actually offer that, by the way. Nitroglycerin, remember I told you to get the pill, not the spray. Aspirin, I told you about, 4-baby aspirin, non-enteric-coated. The pneumonic Mona, remember? Morphine, oxygen, what are you going to use? Nitrous oxide, very good, 4 to 5 liter flow of each. Nitroglycerin, except if the systolic blood pressure is under 90. And aspirin, and if they're not using ED medication. And aspirin only if they're not allergic to it. Those are your drugs to use. And also with an MI, after going through Mona, what do you want to get? The AED, because it's likely after having an MI in your office, the person may then go to a cardiac arrest. So have your AED ready. So rule outs, remember we were talking before, this is for the person that responds a little bit. So it's not this, that's vasovagal. It's not 0 cardiac arrest, but it's in the middle. Rule outs of low blood sugar hypoglycemia, dehydration, anemia, bradycardia, hypotension, stroke or TIA, adrenal insufficiency, cardiac arrest, no response. So you see how the use of spirits of ammonia could be so significant where you're not using it in the way that it's really you've been taught, but you're using it as a differential diagnostic. Also, by the way, a slight reaction could be a seizure that's not going through the seizure level yet. It's still in the oral stage, in the aura stage. So ammonia inhalants we just talked about. Benadryl elixir, we just said it's 50 milligrams, by the way, per cc to give IM in a severe allergic reaction when you give it into the deltoid. 1 cc is 50 milligrams. You could also give 50 milligrams by mouth, meaning elixir form, which is usually 2 to 3 teaspoons. You look at the side and you see how much 50 milligrams is. Nitroglycerin is used, for an angina attack. Nitroglycerin dilates the coronary vessels of the heart by up to 28%, which you need that for that response. With signs of angina, 1 tablet or spray should be administered sublingually. Relief of pain should occur within the first few minutes. Systolic blood pressure below 90 is a contraindication, and Viagra, Levitra within 24 hours, and Cialis within 72 hours, contraindicated to give nitrous. Yes? Yes, of course. I agree. I say yes. Because how do you know that it won't come back? 100%, yes. The incidence of people giving nitroglycerin is very rare. So the fact that you're even giving it once, I would call 911, sure. Hypertensive crisis, nitroglycerin in rare situations can be used for a person who's having a hypertensive crisis, 180 over 120. Okay, and they are having signs and symptoms, or they have signs and symptoms of kidney, ocular problems, or cardiac problems. Nitroglycerin could bring their blood pressure down significantly. Pulmonary edema and angina pain. If systolic blood pressure, contraindicated, remember, if it's under 90, or ED medications. Aspirin is to be used for myocardial infarction. Albuterol, our next drug, can be used as the pump, but as I mentioned to you, the nebulizer, which you can only activate with what? An E-tank cylinder, which you should all have. So for all the money you're saving in some of the other things, buy an E-tank cylinder because it's so important to have. Glucose, okay. So glucose, the glucagon, unfortunately, I will tell you that the use of the glucagon is expensive. It is over $150. But that one time that you use it in that scenario where there's no one coming, you're going to save someone's life. And this incidence of people having hypoglycemic episodes is increasing more and more today. The midazolam is the Versed, which is the drug to use for an epileptic seizure that's in status epilepticus. 99% of the time, when a person's having a seizure, you just have to protect them from not hurting themselves. Okay, that's it. And then call 911, and they will take over. When they get there, what do you think they're going to do? They're going to give them 5 to 10 milligrams of midazolam intranasally or IM, which you could do if it was a blizzard storm scenario or other environmental problem. If you gave too much of this, that's when you get use of the Flumazenil. But again, we're getting a little bit over the top, so that's extremely rare. Listen to the sound of an asthmatic attack.
I can't. What do you mean you can't breathe? I can't breathe.
Listen to her.
My throat's swelling.
Listen to her breathing.
Your throat's not swelling.
Yes, it is. This has happened before.
Why don't you sit down? Amanda, why don't you sit down for a second, okay? Hey, do you want me to get you some water? Do you want some water? I'll get you.
No, I feel nauseous.
You're not nauseous. You're not going to be sick. Just take it easy. Amanda, what? You want me to open the window? Maybe you just need some fresh air.
So, you're hearing, sorry for the cough, you're hearing that it's an exhalation disease. She's getting the air in, she just can't get the air out. Okay, it's a disease of expiration. That's the albuterol nebulizer that you just saw. You want to keep the patient comfortable, 100% oxygen, use of the inhaler 2 times every 4 to 5 minutes. And if that's not working, you're going to go right to the nebulizer or go directly to the nebulizer. Call EMS if 2 doses aren't working. If condition worsens and that's asthmatic attack, what are you going to go for? Your EpiPen. Okay, but remember, if she's 90 years old or he's 90 years old and weighs 80 pounds, Epi Junior, and follow it up with the next Epi Junior right away. So what are you doing in that case? You're actually titrating the dose of the epinephrine as if you were a physician in an emergency room. You don't give them the full dose. You're giving them less because it could be a compromise to their cardiovascular structure and health. Okay, those are the numbers. Okay, this is the use of the lancet. It's a pinprick on the finger, 1 drop of blood, and you could determine what a person's blood glucose is. This is me. I'm doing it incorrectly. Don't do what I show you. Do what I tell you. That is, you want to do that on the side of the finger, not on the middle. It's more painful in the middle. It's on the side. You use the lancet. You get 1 drop of blood. You squeeze it. It comes out. It goes over here. By capillary action, goes up this. Like that, and then within 30 seconds, you get an answer as far as what the blood glucose is at the time. Why do you want to know this? Patient's diabetic, they're losing consciousness. You do a 2-hour procedure, and the patient's leaving your office, and they're not feeling too well, and they have to go home, and they may get into traffic. So would it be so wrong to take their blood glucose before they leave the office? Nice thing to do. Make sure that they eat something before they leave. Make sure that they have a sugar supply before they leave. Okay? So hypoglycemia can be in different levels. You could do this as like in a stop. Okay. Sorry, people. Here we go. Mild below 65 forehead sweating. There we go. A moderate below 50 confusion and irritability, below 30 and even going into coma and seizures and death. So you want to have the potential to use that glucagon to help the person going into severe hypoglycemia with nobody coming for help. Insulin shock continue. What happens 1 hour later? So the person takes their insulin in the morning, realizes they're late to go to work, or we're late to see you as an appointment, get in their car, they drive to see you, but the insulin isn't taking effect until they get later on in the day, meaning about an hour later. And what could happen? They could actually be in a car driving the wrong way on a highway and not even realize it. I gave this lecture in Rhode Island the other day, and a person came over to me and told me that their wife suffers from severe diabetes, and she was going hypoglycemic, gave herself the insulin, didn't eat, and all she wanted to do was get to the refrigerator in order to eat, to get something into her body. And how was she getting there? She was crawling under the bed to get to the refrigerator. And he came home and he found her crawling under the bed. And later he said, what do you do? She said, I was trying to get to the refrigerator. The point I'm making is that you're irrational in this level of low blood sugar. You don't know what you're doing. You could literally be driving down a highway the wrong way and not knowing it. So I'll tell you a little story, okay? Because we have a little time. So it's back 1978. I'm in dental school, and I'm speaking to a friend of mine who we'll call Dr. Ed. And I said, Dr. Ed, what do you like to do? And he says, I like to play golf. And I said, so do I. So in 1979, we played a round of golf. Dr. Ed came to my house. He pulled up in an old Buick Century jalopy car. It's the kind of a car that had push buttons. I don't know those of you that remember. There were push buttons that you used to have to push to change the channels. Okay, not like it is today. And he gets in the car, and we head out to Hauppauge, Long Island, which, Martin, you remember, is way out east on Long Island. And as we're driving out to Hauppauge, we had breakfast first with my wife, by the way. He wasn't married at the time. We get in the car. I'm in the passenger seat. He's driving. We're driving on the Grand Central Parkway to Hauppauge, and it's 6:30 in the morning, and I see a car coming directly at us at 100 miles an hour, and at that moment, he is pushing the button to change the radio station. So what do? I don't say, excuse me, Ed, we got to get out of the lane. No, I take the wheel and I pull it out of his hands completely, and we go over to the side of the road, and the car goes right by us, and we shake like this from the wind of that car passing us, and we survived. And we went and played golf and had a nice round. He came back to my house. We had a nice meal, and I hadn't seen him again for another 30-something years. He comes back to NYU. This is NYU. This is Dr. Ed. This is the dean of NYU. This is the fellow that introduces him. He says, I'd really like to introduce him to the audience, but I also would like to introduce my daughter to his son. You're going to find out why in a few minutes. So somehow during the lecture, someone takes this picture, and this picture winds up in the Lexus magazine, which is the alumni magazine. And some point during the lecture, Ed is looking at me. See, I'm over here. Next to me is my wife. She's out like a light. She had a hard day. She's a librarian. She drove me to this lecture, and she was not. So I said, he looks right at me. I normally sit over here. I sit up, and he's looking at me, and this happens a few times, and I go over to my wife, and I wake her up, and I say, am I bleeding or something? What's going on? Why is he looking at me like this? And she says, no, you look fine. Right after it's out again. Okay. Not that the lecture wasn't interesting. It was very interesting, and you'll find out what it was about in a second. So after that, Ed, takes care of everybody for dinner that came to the lecture. And very nice of him. We get down to the dinner. This is called the Rosenthal area of the NYU. And I said, Ed, why don't we reenact that moment when I pulled the wheel out of your hands? And he says, Dan, I got to tell you. He said, you saved my life. And I said to him, Ed, I got to tell you, at that very moment, I really wasn't thinking of your life. I was thinking of my life. He says, yeah, but if you didn't do that, my son wouldn't have been born. And I said, you do have a point about that, Ed. Because you see, Ed, a little while after that, married a very lovely woman, and they had 3 kids, and one of them's name is Mark, and I didn't tell you that Ed's last name is Zuckerberg. So, Ed is a dentist, went to NYU, graduated in 1978, lives now in your state, Palo Alto area. Used to live in my state, moved a few years ago. And that is the story of how Mark comes about. So Ed is now the father of Facebook. If you go to Ed's site on Facebook, he calls himself the father of Facebook, but, you know, dentist, right? So he says to me, Dan, if you want to be the grandfather of Facebook, by all means. I said, no, it's okay. Thank you very much. I have my own grandchildren, but I appreciate the offer. So there's Ed with his son and wife, Karen, who's a psychiatrist, by the way. You could just imagine how Mark's upbringing between psychiatrist and very technically advanced father. He was the most technically advanced fellow in my dental class. And having those for parents, how he was involved. Anyway, going back to this. So hypoglycemia. All right, back to the lecture. Hypoglycemia, what are you going to give? Sugar drinks. You do not force the patient to drink if they're unconscious. We all know this, right? Only if they are awake do you give them orange juice and things like that. However, but I'm going to tell you something really that many people don't know. And by the way, once the patient is back, you know, they're going into altered consciousness. Remember, AC, you give them sugar and they're okay. One thing you have to know about, there's a drug out there called alpha-glucosidase inhibitors. These are them, Precoce and Glycet. They're a commonly used drug today, alpha-glucosidase inhibitors. And what these drugs do is they slow down the breakdown of sugars. So if a person is hypoglycemic and you're on this, and they're showing signs, what are the signs? Shaky, sweaty, tachycardia, deer in the headlights, belligerent, angry, right? Okay. You give them candy, and what happens to their hypoglycemia? They get worse because the sugar isn't going to get in because it's not going to get broken down. You have to give them something, and what is it? It is right here, pure glucose. In fact, just use pure glucose for everybody. And you don't have to worry about if they're on Precoce or Glycet, because those two drugs, if they're on it, candy's not going to work. Okay, so everybody should have pure glucose in their kits. Another drug to have. Sprayable nitro, pills. All righty? EpiPen, you know the story. Okay, glucagon, midazolam, all to be used as intravenous. Okay, you need syringes, you need atomizers. I'm going to give a few of these out before the end of the day. Syringe and an atomizer together, about $10. The drug, midazolam, $10, $15. Glucagon, expensive. Narcan, cost? Zero. Okay? All right, so if fully recovered from hypoglycemia, they're back. Okay? They're back. You do whatever you want. If they're recovered from syncope, you don't necessarily know if it's just syncope. Remember what I talked about before about it could be hypoglycemia unawareness, it could be urinary tract infection in a female diabetic. There's 24 reasons why a person could go into syncope. 24. If we have time at the end, we'll go over them. But I would suggest the person who has syncope, unless they're 16 to 24-year-old guy, meaning macho man, which is very typical that they can have syncope, you don't schedule. You have the person referred for a physician for a workup. Because it could be anything from a cardiac arrhythmia or dysrhythmia, I should say, to dehydration, to anemia. It could be so many different things. Okay, so that's the glucagon we talked about. And it comes in a liquid and a powder. You mix it together. You use 1 cc. Remember, half cc, half cc. You all know why now, right? You know especially why. Okay, there it is. It could raise your blood sugar by 250 milligrams with 1 cc intranasal. And now you know that was the right answer I got to you before. There's the Precoce and Glycet. When they're on that, remember, give them pure glucose in that form. Okay, so now when it comes to diabetes, a male's risk for heart disease begins to rise at the age of 45, but for a woman, it does not increase till the age of 55, 60, meaning postmenopausal. However, diabetes closes that gap. Women under the age of 60 with diabetes have 4 times the risk of heart disease, making them at risk equal to or greater than their male population. Average age for a male with first cardiac event is 64.5. For a woman, it's 70.3. However, if she has diabetes, the risk factor it increases the chance of a cardiac event by 4 times to below the age of 60. So diabetes is an equalizer in females to have the same risk factors that we have as men. So hypoglycemia, I could tell you all day about what all this stuff says with shaky, fast heartbeat and sweating, or you could read this, which are all the other things, but if you listen to this for the next 30 seconds, you'll never forget.
You have great hair, and your scalp's as clean as a whistle. I tried. Well, it must run in the family.
Deer in the headlights?
You've got the prettiest head of hair I ever had my hands in. So thick. Well, just because I'm bragging on you don't mean you get lazy on me. Hold it up.
You're going to see agitation.
Shelby? Shelby! My man!
I'll get some juice.
Truvy, there's some candy in my purse. I have some up here. Shelby, hold on. Clary's getting you some juice. Shelby. Should I get her a cookie? No, juice is better. Here's the juice. Shelby, you need some juice. You need
Sweating,
some juice.
shaking.
Don't drink the juice.
Belligerent?
Please drink the juice.
No! Stop it, Mama! In my purse.
No, you didn't bring your purse, sweetheart. You didn't bring your purse.
And she's not
no,
going to remember
you
this.
didn't. No, here you go. There you go. Drink some of this. It's not any wonder with all this running around and wet nonsense.
Excuse me, should I call the doctor or something?
No.
She's a diabetic.
She just has a little too much insulin, that's all. We'll just get a little more in it, she'll be all right.
If you don't leave me alone, I'm gonna leave.
Oh, I'd love to see you try. Cooperate, please. Honey, drink, please. Come on now. Come on, girl. Yes. There you go. There. That's a start.
So in real life, the music doesn't slow down. So, but it's good to see this, because this is what, you know, a funny story I can tell you about this is that someone who saw this when I was originally giving this lecture in my office went to see their grandmother at a family reunion, and it was a dental assistant in my office who saw this, giving it to the office staff and people that came for the lecture, and she saw her grandmother act exactly like that, and she was the only one in the room that knew exactly what to do. And she wound up saving her grandmother. So little things like that. There was a book written by Gary Taubes called The Case Against Sugar, and in it he states sugar is the tobacco of the new millennium. If you want to know why diabetes is getting to the point that it is, get this book. It's really very well written. The Case Against Sugar by Gary Taubes. I saw him present that, by the way, at the 92nd Street Y. So seizures are convulsions. Back in 1997, there was an episode of Pokemon that was shown in Japan, in Tokyo. And after watching this episode of Pokemon, what happened was the characters went into a box. And when they opened up the box, there were these intense flickering of light. So intense that it turned out that there were 685 people that went to emergency rooms from seeing this on television, and 10,000 people became really severely nauseous and had problems. The people that went to the hospital, by the way, some of them weren't released for weeks. It was that serious. Why? We all seem to have a threshold for when we can experience a seizure. People that are epileptic, when there are flashing lights, can go into a seizure if the intensity is that strong. So we all have that level. What you just saw, I should have warned you not to look at that if you have that issue. But if you I forgot about that. I had one person in 10 years said they felt a little nauseous from that. I hope not tonight. If you are passing a police car at night and the lights are flashing and it's very dark, and as you pass by, you get that unusual feeling, you have that issue with that threshold. Reasons for seizures: hypoglycemia, cerebral hypoxia, local overdose stress. Now, I'll talk about hypoglycemia. If your blood sugar goes really down, you're not just going unconscious, you may then go into a seizure. And the treatment for it is going to be what? The glucagon, okay? Not Versed or midazolam, which is the treatment if it's epileptic in nature. Okay, so you could have the seizure being caused by epilepsy, and you could have the seizure being caused by hypoglycemia. If the person was having a seizure right here, right now, and it didn't stop, and we had paramedics running into the back of the room there, and they came up to that person, one person would be taking their vitals, the other person would be doing a stick, and they would be giving that person the sugar. They would be giving that person the glucagon, because the point is that the sugar isn't going to hurt them, and it may be getting them out of the seizure. So a very common reason for people having a seizure is hypoglycemia. Another reason for a person having a seizure is cerebral hypoxia. So, again, I'm sorry. Person is sitting up and faints. They're sitting up and faints. And nobody thinks to lie them down. Okay, so they're sitting up, let's just say a person is sitting in the waiting room, and here's a family member scream when they get a local injection, and they're in a sitting position in the waiting room. Well, as they're in that sitting position, they faint. They're unconscious, but they're sitting up. The next thing that happens is within a few minutes is they may go into a seizure because they're having cerebral hypoxia. Their brain needs oxygen, but they fainted. All they have to do is lie down flat, and they're getting the units of blood injected to their brain. But if they're sitting up, they're having cerebral hypoxia, the next thing is seizure. After the seizure, they can go into a cardiac arrest, and they can go into a coma, and then they can die. All because they didn't lie down. All right, so everyone that's having a syncope has to be lying down. So another reason for a seizure, cerebral hypoxia, because you're not getting oxygen to the brain because you're in an upright position. Stroke, another reason for a seizure. So all these are possible reasons, and the person's not epileptic. So hypoglycemia, cerebral hypoxia, local overdose, and stroke. Local overdose, it shouldn't really say overdose, it should say hypersensitivity. How many of you that have given many locals for many years, after giving a person local, the person starts to do this? Okay, have you seen it? I see people that are experienced and mature nodding yes, okay? Because I've had it happen to me at least a dozen times. So you give local, and what that is really a person who's hypersensitive to the local anesthetic. And it's a mini seizure. And those of you that have seen this happen, by the way, the people that haven't seen it happen, it's going to happen. Okay? Eventually, I see many of you are young. It's going to happen in your career that you're going to give some local and the person's going to start doing this, and then their feet are going to start to shake, and then their whole body's going to shake. And it is scary when you've never seen it happen before. The treatment for it, remember what I talked about oxygen before? What does it do to the threshold? It raises the threshold for the seizure to continue and to recur. So if a person starts doing that, give them 100% oxygen, and that will be over in a few minutes. If you don't give them the oxygen, it can take 8 to 10 minutes. Those of you who have had this happen, you know it's 10 minutes of terror the first time you've ever seen it. So those of you that haven't had it happen, you know a little trick. Seizure threshold altered by fatigue, malnutrition, lack of sleep, hypertension, diabetes, neon or strobe lights, rapid motion, antihistamines, and stress. I'll show you an example of a seizure. This is in the movie The Andromeda Strain. There's a flashing light. The person has epilepsy. She's a scientist working on a project there. She sees the flashing lights, and that's enough to cause a seizure. What happens in a seizure is you have your carpal pedal spasm, arms coming in this way. See, you don't want to have people like that working for you, okay, that run away.
Someone bring 100 milligrams of phenobarb in a syringe, fast.
All right, so the back is arched. Sometimes the only part of the body that's going to be on your dental chair is the ankles and the neck, because the rest of the body will be arched off the back of the chair. Sweating, profuse sweating. She's going to become incontinent as well. Sweating. And at this point now, she could be given the, well, at this point, you're going to do nothing other than just maintain her so she doesn't hurt herself. And EMS is going to be there in 10 minutes, things will be fine. It's when they're not going to be there that it goes into status epilepticus for more than 5 minutes that you consider to use the Versed. 1 cc, 1 cc, 5 milligrams, 5 milligrams. You get 5 milligrams per c prescribed, and you could use that in each, 1 cc in each part of your nose. Okay? Signs and symptoms, the aura, the stiffness, the loss of consciousness, loss of bladder control, confused and fall asleep after the loss of consciousness. They will have a white foam in the mouth. That is a combination of oxygen with saliva. That's all that is. And it should be suctioned after the seizure. You want to give them oxygen as soon as it's over. This will raise the threshold for a second seizure. Also, take a blood sugar, because a blood glucose level with your glucometer, because if it's coming from low blood sugar, you want to give them the appropriate medication, meaning the glucagon. Old days it was Valium. Now it's midazolam. Valium, if you really don't like your patient, you want to give them Valium IM because it hurts like terribly. Valium is meant to be given intravenously, but since you're not going to do it IV, most of you use the midazolam intranasally if needed, and 5 milligrams, 5 milligrams, a total of 10. So that's the drug to use if you're giving too much midazolam, but this is extremely rare, so I'm just going to skip it. These are all the new drugs now to use intranasal: glucagon, midazolam, the naloxone, you know, of course, flumazenil, and the Narcan. And also nitrous oxide. Why are we using nitrous oxide? That's the 10th drug in the kit, because it is what? For pain of a myocardial infarction. Right, very good. Okay, and that ends the, now also I want you to put in the kit the color-coded cards, which I'll send to you. There they are, okay? And you all know what every color is, okay? As the 11th part of the drug emergency kit is your hands. Now, why am I telling you your hands? A person who's hyperventilating, panting, right, from stress and loss of CO2, that you have to get their CO2 to come up. So what in the old days did we used to do? Get a paper bag, remember? Forget the paper bag. Paper bag is out. Now it's have the patients cup their hands like this, put their hands in front of them like that. Why? Number one, their hands are frozen, peripheral numbness, and they're cold. So having them put their hands, having them be proactive in their own treatment is good, number one. Number two, they're breathing their hot CO2 out of their lungs to their frozen hands on the inside is helping them psychologically get better. And number two, what you do is you put your hands on top of their hands, so you help as the health provider, putting your warm hands over their frozen hands. So they've got your warm hands, they have their warm CO2. The CO2 is rebuilding. They have warmth, psychological getting reversed. It's a win-win-win situation. And that's what you do for a person hyperventilating. Okay? So what is the one drug you don't give to a person having hyperventilation, by the way? Oxygen. Okay? Because if you give oxygen to the person who's hyperventilating, they're going to get worse. They need to have their CO2 go up, and the only way to do that is paper bag and or this. But this is much better. All righty? Oxygen is the answer. So, and the AED, which 90% of you have, those of you that don't have an AED, make sure that you get one, okay? Because, you know, you're just not going to see that patient again. And by the way, you shouldn't only have an AED in your home, in your office, you should also have one in your home. If you feel that you want to save a person in your office, why wouldn't you want to save a person in your home when you have Thanksgiving or holiday meals, and, you know, you have your Uncle Frank or your Aunt Rose there? I mean, you're not going to see them next year if they have a cardiac arrest, or I should say 4% chance. So you really should have one in your home. In fact, I'm even thinking of putting one now in my car as well. So it's a good idea. This is the point where I would get some coffee during the lecture, but we're going to go right through it. So we're doing some prizes now. Singer and movie.
They call you Lady Luck.
So who's going to tell me the movie and the singer? And the movie? Right, who said Guys and Dolls? Very good, you don't get a prize for that, but I got you in the mood to answer the next question, okay? So you should have first dibs at the question. Are you ready? Okay, so tell me what the numbers are here. Rate pressure product is defined by what blank blood pressure, what is this then, and what is that number? So I have to see a show of hand. A person raise a hand for this. Okay, we're gonna going once. I'm gonna give you a pulse oximeter for this. You have to tell me what this is. Blank blood pressure times what, over what number indicates possible oxygen deficiency to the myocardium. And by the way, this is not an absolute. This is like an idea. Okay, and any of the numbers? Okay, go ahead. Systolic, right, and times the, right, and the number? Right, exactly right. Okay, I'm going to throw this for you. You ready? And here you go. Good catch. All righty, so you got it exactly right. All right, so there we go. Systolic times pulse, 13 to 15,000 indicates possible. See, I say possible. All right, you know, as dentists, we don't have EKGs. We don't have urinalysis. We don't have a blood test. We don't have a chest x-ray on all the patients that walk in. But a simple thing like this could be very, very helpful. Because people ask me whenever I give this lecture, at what point do you not treat the patient? You know, is it a diastolic of 100 and over you don't treat them? It's more than that. You know, it's this number in addition to their blood pressure, in addition to their pulse. And if their pulse is, you know, abnormal. By the way, a lot of the pulse oximeters, when you put them in, you know, put their finger in the pulse oximeter, you can actually see their pulse, and almost like an EKG on the pulse oximeter. And this is for only $40 to $50. When I first had a pulse oximeter in my office, it cost thousands of dollars back 30 years ago. And now you can get it for $40 to $50. Question, go ahead. Oh, that's an EKG. That shows you a rhythm, an EKG. I don't think you need it in the office, no. But people that have dysrhythmias are obviously using it to send that code back. Yeah, of course, but not really for a dental office. I think this is significantly more important. So next prize I'm going to give out is, what is this? Muller sign. Does anyone remember what that is? Yes. Right, vibrating uvula. Very, very good. So what are we going to give you? Okay, I have just a few things left. I'm going to give, but you know what? How are we doing? We are at 8:30. Here you go. Ready? And great. Okay, very good. Very good. Excellent. A bad throw. But good catch. Okay, so right, it was a pulsating uvula. It indicates aortic insufficiency or aortic regurgitation. So we're going to get more into, we have now half an hour, we're going to get more into what syncope is. Remember I told you all those different possibilities of syncope? So we're going to talk about the definition of it, but that's not important. What we're going to talk about is the causes. 23 possible. Vasovagal, cerebral hypoxia, or hypoglycemia. You all know if your blood sugar is down, you could faint, right? You could even go into seizures. Cerebral hypoxia means the person who faints sitting up, they're not getting oxygen to the brain, they're going to faint, they're already fainted, they're going to go into a seizure. Vasovagal, the most common cause. What happens with vasovagal is there's peripheral venous pooling. You have less venous return. It's supposed to trigger our baroreceptors to trigger to get our epinephrine to come up. But what happens is with people with vasovagal, it doesn't work. They have a defect in their C fibers that go to the brain. It's a whole big sequence of events that happens, but it's a parasympathetic response. The vagus nerve gets stimulated. That's why it's called vasovagal. And they are unconscious. They actually go through a very transient point where they have transient asystole. The heart actually stops. Then they come right out of it, though. Cerebral hypoxia, remember, is a cause. Here's an example of cerebral hypoxia.
That a simple emergency may evolve slowly or change quickly into a more complex or dangerous situation. Here, grand mal seizures caused by cerebral hypoxia developed after a stress-induced faint. When a new emergency situation is recognized, the dental team must repeat the emergency algorithm sequence. Thus, positioning the convulsing patient to prevent injury immediately follows recognition of the seizure. In turn, ensuring an adequate airway, breathing, and circulation must quickly follow to detect and treat any change in these vital areas. Only after these steps are taken should definitive therapy be considered.
You fainted. You're doing fine. Let's take a blood pressure.
Seems that he needs the blood pressure in that scenario more than the patient. So hypoglycemia is another reason for fainting and unconsciousness. More reasons: anemia, anxiety, epilepsy, malabsorption issues like iron deficiency anemia. People that get iron deficiency anemia are oftentimes people that are very healthy, people that are weightlifters, people that are runners, people that are vegetarians because they're not getting the meat. The runners and the weightlifters, if they're really doing it a lot, they actually could bleed into their muscles the more they do it, weightlifting and running. And if they're vegetarians on top of it, they're setting themselves up for a deficiency. And how do you see that? Pale gingiva, pale conjunctiva, angular cheilitis on the corners of the lips. Another issue that you could see is all of you turn around and look at your palms and look at your lifelines in your palms. When your lifelines are the same color as your skin of your palm, you're probably anemic with a hemoglobin below 10 to 9. So seeing those lines is an indication of almost looking into our capillaries. And when you see that they're darker, that means that you're not anemic. So a very simple test that you could look at. Causes that is using the mnemonic HEART, H-E-A-R-T. H is for heart attack, E is for embolism, A is for aortic stenosis, R is rhythm abnormalities, and T is for tachycardia. Other reasons, from a hypertensive crisis to a local overdose like we talked about, but really that should be a hypersensitive person. These are other things: gastric bleeding, stroke, aortic regurgitation. These are associated with pain. So a subarachnoid hemorrhage, aortic distension, abdominal aortic aneurysm, pulmonary embolism. We talked about that, remember? A little pearl about that is a person with a low pulse oximetry, like high 80s, especially a pregnant female, maybe having a pulmonary embolism. You could rule that out. Ectopic rupture in pregnancy. So I'm going to show you an example here of examples of people in syncope. What a patient states, they will tell you, I don't feel well. They say, I don't feel good. We say in New York, be sick. The room is too hot. I feel dizzy. The room is turning black. Here's an example of it in the movie that you might know.
I look up. I look down.
Right. Okay, another example in the movie Sleepy Hollow with Johnny Depp. Watch the whites of his eyes. There he goes. Okay, so sequence is that peripheral venous pooling as we talked about. Pale to slightly cyanotic in the nails and in the lips, sweating, eyes roll back, sensation of warmth, lightheadedness, malaise, nausea, pupil dilation, peripheral coldness, visual disturbances. So all these things are possible. Oftentimes caused by fear and pain, obviously things that may associate with them coming to our office. Positioning of the patient is so important. Remember, lying the patient supine. I've told you this 3 or 4 times. A little way to remember this, SOS is my 3 letters to remember. And so who sings it? What's the group? Right, and the name of the song? Message in a Bottle. Right, okay, and he says, I'll send an SOS to you. So what's S? Supine. Remember, anyone that faints, think of police, message in a bottle, I'll send an SOS, supine, oxygen, spirits. But when do you give the spirits? Do you give the spirits at first thing? How long do you wait before you even think of giving the spirits? Right, 15 seconds, even 20 seconds, okay? And then if there's no response, what are you thinking about? Possible Cardiac arrest. And what are you going to say? And what are you going to say? Are you going to say somebody get the AED? You're going to say that person's name. And that person repeats your name, and that's closed-loop communication. And now within 30 seconds, you have an AED on that person. You could really save their life. Big difference than doing it the routine way. So this is often the only treatment necessary. Position. By the way, how many of you people know the rules in real estate? It's location, location, and what's the third one? Right. You know what the three rules are when it comes to syncope versus stroke. It's position, 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 and I'm going to show you why. So a person's having a stroke, okay? How do you know? FAST, the Cincinnati Stroke Test, FAST. F stands for facial drooping, A, asymmetric pressure, FAS is slurred speech. So you tell the person to hold two arms out and one arm will fall down. They have facial drooping. They have slurred speech. You say, can't teach an old dog new tricks. Can't teach an old dog new tricks. They can't say it. If they have all three of those, FAS, then T comes into the picture, which means they got to get to the emergency right away. Why? To get TPA, so that they can unclot the clot, okay, which is not 100% of the time now. A clot as a cause for a stroke is 80% of the time. It's called an ischemic stroke. What's the other 20%? Who's going to tell me? Hemorrhagic, right. So a person who's having a hemorrhagic stroke is in your office. They're going through FAS, you see they're having a stroke, and they say to you the following words: Doc, I am having the worst headache I've ever had in my life. That's not pathognomonic, but it's likely to be hemorrhagic stroke. So what do they ask you for? They say, can I have an aspirin? They have the worst headache they've ever had in their life. And I'd like to lie down. If it's hemorrhagic stroke, what could you be doing for that person? Not anything good, absolutely making them worse, okay? So a person who's having FAS in the Cincinnati Stroke Test Assessment, facial drooping, asymmetric pressure, slurred speech, they say they're having the worst headache they've ever had in their life, and you shouldn't give an aspirin. Now, in general, if they're not saying that, they should get an aspirin, because the aspirin will prevent the clot from getting worse if it's non-hemorrhagic. And you want to give an aspirin also for a person having an MI, okay? So those are two reasons. But for a stroke, so a person having a stroke in general should not be flat, okay? Should be upright, because it may be hemorrhagic. And a person in syncope should never be upright. They should be flat, okay? So simple, simple little test. If you learn nothing else today, and you don't even have a drug kit in front of you, you can save a person's life by just having them in the right position with stroke versus syncope, okay? So I'm going to show you that as a, I'm going to show you that in a diagram. Let me put that right here. Okay, we're going to go through the brain, and then we're going to spin that around. We're going to go through a chart. We're going to work on the brain first. We'll go through 3 organs and 2 situations as far as emergencies. So we have the brain, the heart, and the lungs, low oxygen, low blood flow, and a blood clot. So we'll go through these 3 things. I like to think, keep it simple. You know the KISS technique? Keep it simple and stupid. Let's not make things too complicated. Brain, low oxygen is a seizure. Low blood flow is syncope. Okay, again, all available to you on the PDF. You don't have to write any of this down. A blood clot to the brain, you know, is going to be what? A stroke, but not 100% of the time. The other 20% of the time is hemorrhagic. Okay, so when it's hemorrhagic, that is, you want 20% of the time, and it's position that's so important, and you want to have that person supine when they're in syncope, and what when it is a stroke? Upright, because you don't know that it's not hemorrhagic. You don't know that. You don't have that test. You need an MRI or a diffusion-weighted MRI, which is a whole new thing that they have today. So administer oxygen, aspirin, yes or no? Okay, well, myocardial infarction, yes, unless they're allergic. And stroke, yes, unless they tell you they're having the worst headache in their life. Okay, because in general, the stroke should get the aspirin. Okay, if they're allergic, no, and severe headache with stroke, you might want to hold back on the aspirin. Okay, now the heart. Okay, if we have low oxygen, that's angina to the heart, and we have myocardial infarction, if it is a clot. Okay, low oxygen to the lungs is going to be what? COPD. And a blood clot to the lung, that is the infamous pulmonary embolism. Okay, remember, pregnant female, high 80s in the pulse oximetry, you just may have saved her life. So, up to 10 reasons to give oxygen. Remember we talked about all these before? Angina, rate pressure product 13 to 15, oxygen below 93, macho man, asthma, severe, patients with history of seizures not responsive, history of CHF, exertional dyspnea, patients with MI, in the past 6 months. Rate pulse product over 13 with a high body mass index over 30. Third trimester of pregnancy and having respiratory difficulty. Women differ than men. And there's a lot of women here today, so you're going to be there's important information as far as their heart and signs and symptoms. We talked a little bit about it before. So women complain in a myocardial infarction of extreme fatigue. Remember the thing I mentioned to you that long-standing diabetics have? Also this extreme fatigue or feeling like they have the flu. Women also can complain of this as their telltale sign. Also, this is interesting, belching indigestion, not after having a gallon of 7-Up, okay? But just that, belching and indigestion can be an indication. Pain for women, often associated in this location in the back. Men, it's more often here, unless they're diabetic, okay? But pain here in this area. And remember, 50% of the time for females, you don't even know it until you get an EKG at a later time. Shortness of breath in females is mild, whereas men it's usually more severe. 50% of the time, remember, you don't even know you're having it. So how to save your own life. Okay, we're at about 20 minutes left to go, and this is something that I mentioned as part of the title, How to Save Your Own Life. 3 major factors we know today are undiagnosed hypertension. By the way, the number of people that have hypertension, only about 20 to 30% of them are treated well. In other words, their hypertension is under control. So when they come into your office and tell you, I'm taking my medication, you don't have to take my blood pressure, it's exactly the opposite. That's the people you really have to take their blood pressure because they're not very well maintained. A lot of them are not compliant on their medication because they have side effects from it. They don't take it. You know, people with diabetes, a lot of don't take their insulin correctly. Why? What does insulin do to the diabetic? It makes them gain weight. What's one thing they don't want to do is gain weight. So there are reasons that people don't take their medication. So hypertension undiagnosed is a big factor. It leads to multiple problems, one of which is when you don't have hypertension, your vessels look nice and smooth like this. When you have hypertension, you develop these little indentations in your vessels called tight junctions. These tight junctions are where your plaque and vessels accumulate, which then break off and cause you to have an MI. So tight junctions. Another problem with people with undiagnosed hypertension is aneurysms. Okay, and I'm going to tell you a little trick. When you're over 30, 35 years of old, we all have little aneurysms that develop somewhere around our body because almost all of us get some degree of hypertension. Unless you walk 7 hours a day, okay? So, and many of us don't. So if you have like an aneurysm, aortic, cerebral, and you sneeze, and what is the politically correct way to sneeze? Okay, the politically correct way is what? One of those, instead of one of these or these or these. If you do one of these and you have an aneurysm, what might you do? Kill yourself. So I will tell you that when you're over the age of 35 and you have to sneeze, be safe and sneeze. Not in someone's face, but that's what a jacket's for. And that's why you turn your head. That's why you put your hand here. But when you hold that in, if you have an aneurysm, you can kill yourself. So careful, and word to the wise, over 35. Tight junctions, LDL, the bad type of LDL. There's 2 types of LDL we all think is bad, but there's 2 patterns, pattern A and pattern B. Pattern A is good, large and buoyant types of LDL. They keep bouncing along. Okay, people have this like in northern Italy and in Japan. They live to 105 and they have all the fat and worst possible things you could eat, but they live forever. Pattern B is the small and dense kind. That's the kind we all have, okay? Unless you're very, very lucky. But pattern A kind, you could live forever and eat whatever you want. It's the combination of the 1, 2, 3 punch. It's the hypertension, the LDA type, and the inflammation being the third factor that all add up to create a scenario for us where when we have recent plaque and red blood cells that break off with that bad LDL causing high inflammatory issues, we have potential for cardiac arrest and myocardial infarction first. Most common area for that is going to be this is a red blood cell getting packed. This is the tight junctions I mentioned to you. You can see the tight junction here and here. Once these things get close, you get all this plaque buildup. When this breaks off, it can cause the occlusion down the road. So it's the tight junctions, the LDL type, the type B LDL, and the inflammation, which is judged by what? C-reactive protein. Okay, that is an important test we all should be getting. Occlusion of our vessels can occur, and the way to live through this type of a situation is what? The development of collateral circulation. How do we develop collateral circulation? Well, for all of us in this room that are young and have growth factors going around in our blood, What you do is you want to walk an hour a day. Remember I talked about 7 hours of walking will give you no diabetes and no cardiovascular problems. But if you walk an hour a day, the first 30 minutes is good for you, but the second 30 minutes of continuous walking starts to develop collateral circulation. Another way to do it is to do this. Go on a treadmill, bring it up to 4.2 miles an hour, and put it at an incline of 4, okay, which is about 17 degrees, and maintain that for 10 to 12 minutes. Any minute you go past that, you're developing collateral circulation. Collateral circulation, as long as you have growth hormone still working in your body. I see 90% of everyone in this room has growth hormone, so you can do that. Now, I'm not going to tell you to just do that when you leave there tonight and go on your treadmill, because what is that? It's called a stress test. It's called the Bruce protocol, and you just don't want to do that, you know, without making sure and asking your doctor that it's okay. But that is a way that you can actually live through a myocardial infarction, having this collateral circulation that can develop around it, and you could live through it. The number one vessel that's affected with that is your left anterior descending coronary artery. And that is the one, and once that goes, it's the left ventricle that's affected, and once that left ventricle is affected, you cannot regain that. So if you have that go for too long, you get a necrosis of that area. These blood clots can occur. They rupture, causing the clots. It's a 1, 2, 3 punch, as I mentioned. C-reactive protein, one of the most important things to test yourself of to make sure that it is low. When it comes to women, having high C-reactive protein is more important than having high cholesterol. Aspirin and statins lower your C-reactive protein. If you win one of these pulse oximeters, when you wake up in the morning, put it on. If your AM pulse is 90 and over, you're in big trouble. If it's 60 and under, you're as good as could be. So working harder physical activity over the long term can make you have these collateral circulations. This is a heart that is without a heart. This is just the collateral circulation of the coronary vessels around the main coronary vessels with just collateral circulation. So it takes 75% blockage of a heart of a vessel to have actually signs and symptoms of pain. So when you are 75% blocked, you know, you hear people that say, oh, I had 90% blockage or I had 98% blockage. When you have 75% blockage, you could run a marathon. When you have 80% blockage, you begin having pain, and as it goes higher and higher and higher, that's the point where you can't even get out of bed and get to the bathroom without being out of breath. But 75% blockage, you're fine, which is really not so good, because the difference of 75 and 80 is not much, okay? And this is the blockage, you know, at 80%, and you can see that a stent is going to be necessary to do that. So we're at the end. We're going to do some questions. I'm going to do the never list, so we're going to think in opposites. The never list. Never give oxygen to a patient who's hyperventilating. True? True, right? Never give oxygen, so we all remember that, right? Never hesitate to give epi to a patient in anaphylactic reaction, and you know now what constitutes anaphylactic reaction. Never give nitro if the systolic blood pressure is under 90. We all know that. Never give nitro to a patient who took Viagra within the last 48 hours. Okay, and if you don't believe me, you'll find out about that now.
It's puberty attack. Yeah. Give me an aspirin, Topical 5 milligrams, and hang a nitro. Mr. Sanborn, your EKG shows you have a blocked artery which is not allowing enough oxygen to get to the heart muscle. Heart attack. We're going to stop it, but I need to know what medications you take.
I take Lipitor.
To this.
Anything else?
For blood pressure.
And what about Viagra? Mr. Sanborn, did you take any Viagra today? Mr. Sanborn?
No. No Viagra.
Okay, good. Just need to be sure, because I put nitroglycerin into your drip. And if you had taken Viagra, the combination could be fatal.
Now you're going to remember, right? Okay, make sure to ask it. By the way, when you ask men if they're taking ED medication, they all say no. So you really have to say, you have to be serious about this, because if they're having a cardiac event, you have to know. Never place a patient upright who is in syncope. Syncope, fainted, never put them up. Why? They're going to have what? Cerebral hypoxia. They'll wind up going into a seizure. Never place a patient supine who's having a suspected stroke, because you don't know if it's not hemorrhagic. And if it is, and you do this, you could make them worse. So just position is everything in that scenario. Okay, don't schedule patients on Monday morning.
Can't trust that.
The mamas and the papas knew that. It's the worst time for cardiac event. Has to do with this circadian rhythms, okay? Okay, question, here we go. So what am I going to give you? I'm going to give this person a nebulizer, plus an atomizer and plus the syringe for it, okay? So, because I have about 4 or 5 presents left to go. So this is a combination present. You got to give me 2 diagnostic criteria for when you give the EpiPen. Is that a hand raised? Yeah, okay, go ahead. Right, and? I'm going to give you a hint. I'm going to give you a hint. Blood pressure, right, you said it. Exactly right. Now, by the way, I want to show you something. So remember what I told you before in the beginning of the lecture about how we freeze during an emergency? All of you, when I call on you to answer these questions, you're going to know the answer, but you're going to freeze. And I'm just bringing the point home that you know the answer, but when epinephrine starts going in your body, you can't think straight. That's why you have to remember the colors for the emergencies, okay? So, right, it's how to differentiate is the blood pressure and the respiratory compromise, meaning the high-pitched sound. Incontinence, by the way, and also abdominal pain are others, and with children, it's below 30% of their original pressure. Give me causes of seizures, not from epilepsy. We reviewed it a little bit. You know, in the full-day course, we go over these things about 3 times or 4 before so you really, really get it. But this is an abbreviated course, so can anyone tell me? Give me 2 reasons. Wait, you got to raise your hand. Don't shout. So if you can give me 2 reasons why a person would have a seizure that is not epileptic. Okay, so a person having a seizure, but they're not epileptic, give me 2 reasons for it, and I'm going to give you a glucometer. Okay. Right? Exactly. Okay. All right, now you're a far throw. Hold on a second. Can I do this? Here we go. Ah, bad throw. Good catch, though. Okay. Very good. All right, so you got it. Exactly right. Cerebral hypoxia, hypoglycemia. The other one is local anesthetic hypersensitivity. Okay. Give me 4. That's not the song. You know, people tell me Rhapsody in Blue whenever I do this. So give me 4 emergencies that can occur just by looking at that. Give me 4. Who's going to raise their hand? Somebody raise their hand because I'm going to show you something really that I'm a really nice guy. Are you ready for this? All right, nobody gives me 4. Ready? What about this? I knew 4 was hard, but I think 3 you're going to get. So you just look at that and what kind of an emergency are you going to have if you're the patient? Well, you got to be 3. Can you give me 3? Okay, try. Go ahead. Yeah, syncope for sure. Hypertension, yes. A person who's hypertensive. No, you're not going to get hyperglycemic or hypoglycemic from looking at that. But you got 2 out of 3. So you got, yes, seizures. Exactly right. What are you going to do with that tomorrow? You're going to put that on as soon as you get up in the morning before you get out of bed. And if it's absolutely. Yeah, exactly. Well, congratulations. Okay, so here they are. Ready? Very good. So angina and angina attack, an asthmatic patient and asthmatic attack, a young healthy patient syncope and also hypertensive crisis, young healthy patient hyperventilation, especially a person who's nervous. Epileptics can have a seizure and angina and angina attack. So good. Okay, I think I have just one really good prize left, and that's this. You remember this? I gave you this in the beginning. A lot of reasons for peripheral numbness. I'm going to give you a hint. The hint is starting with hypers and hypos. So that's the hint. You got to give me 3, but you got to raise your hand. Who's going to raise their hand? Things that start with hyper or hypo. Oh, wait, you got to raise your hand. Who's the person? You're going to go for it? Or you got to give me 3. So what? Hyper? Right. That's it. That's 2 out of 3. Now you just need 1 more for peripheral numbness. And I'm going to give you a little hint. Yes, hyperventilation. Right, here you go. Good catch. Very good catch, by the way, over there. Okay, so you guys got it. All right, now listen, before you go, I'm going to show you that remember I told you you can't save a person's life because you can't get an AED on them in less than 10 minutes, right? How often do paramedics get there? And even if they do get there, they may not be having the AED on the person in 10 minutes. And your likelihood of dying in a cardiac arrest is it's really 8%, but up to 10% every minute. So at 10 minutes, it's almost 0% survival. It's really at about 12. But anyway, you don't want to be defibrillated at 12 minutes because of the quality of your life that you'll have at that point after. There is a way to get an AED on a person in less than 10 minutes, even if we don't have an AED here. Okay? And it's being done in Reno in the United States, and it's being done in Europe, in the Netherlands, and it's being done very successfully there. Maybe one day we'll have it in this country, but right now you can have it happen and watch. But one thing I want to tell you about is, you know that your batteries have to be replaced every 5 years with your AEDs? How do you know that? Because it's going to be the beep, 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 beep that you hear on your AED that you can't figure out what the sound is. You know that it's not your phone. You know that it's not your whatever, your alarm. And it's the sound that's the weird one. And then you're going to realize, you remember I told you this, oh yeah, when we heard the beep that we couldn't figure it out, it's the battery on the AED. That's number one. The pads are supposed to be replaced every 5 years also. But don't throw out your old pads. Keep your old pads, and you're going to see why.
112 operator, what is your emergency?
It's my dad. I think he had a heart attack. Please help, he's not breathing anymore.
Please stay calm. What's your name?
Joanna.
Good, Joanna. We've got your location. The ambulance drone is on its way. Remove his top shirt to uncover his torso.
So the GPS in her phone gives the location. The ambulance drones are in every zip code in the Netherlands.
Go to the nearest exit. The
It flies at 200 miles an hour. It gets to the location where she is. She'll get it outside the door of the building.
I'll be talking through the drone now, so you can
the
put down...
doctor's going to run the code through the camera in the drone. In the drone is an AED.
And bring it to your
She's bringing it to her father. Look at the time that's gone by. 1 minute.
Great. Okay, pull the green lid. Now place the pads on your father's chest.
Notice what's on his chest.
I can see that the pads are properly applied. Joanna, please stay clear of your father. We'll take it from here.
80% chance this is going to happen. That doesn't happen in 10 minutes. So this is the fellow that came up with this in the Netherlands, at the equivalent of our MIT.
Hi, I'm Alec Momon. I'm a graduate student at the TU Delft, working on a project for Living Tomorrow and UZ Gent. Our vision is to improve current emergency infrastructure with a network of drones capable of saving lives. At over 100 kilometers per hour, these drones create an ultra-fast response system capable of increasing this survival chance from 8% to 80%.
They say 8% to 80%. But I told you not to throw out your old pads. Keep your old pads, because if a person has a lot of hair like that fellow did, what are you supposed to do? You're supposed to shave them, right? You're going to put lather and a razor, and you're not doing that. What you do is you keep the old pads. You put the old pads exactly in the positions which we all know. First thing we learned in the lecture tonight, here, here, and what do? Wax them. Now here's the thing. If the person is not having a heart attack at a cardiac arrest, they wake up immediately. And that's why you keep your old pads, everyone. And that's all. And if you want to really have a cardiac arrest, when you come to New York, go to my favorite deli called Katz's. Mr. Katz in 1898 asked the sign man for a sign. He said, I want to have a sign. It's called Katz. The sign man said, anything else? He said, no, Katz's, that's all. That's the sign. Katz's, that's all. And that's my wife. I had to show a better picture of her rather than just sleeping. Otherwise, I get a lot of aggravation. So that's, I said, when you heard this, you'd be done. We should have Layla. Somewhere there? There we go. All right, Layla, and good night, and thank you, everybody, for coming. And we just did it at 9 o'clock.
Exactly so.
Okay.
Thank you, Dr. Pompe.
Thank
that
you.
was wonderful.
Thank you. Thank you.
Thank you all for coming. Your CE credits are on the table where you came in. Please come to our future events. These flyers should be in your mailbox already.
Email.
And don't forget Dr. Pompa's email, dpompaoms@gmail.com. We're going to put that on our website as well. So if you've forgotten that or have any problems with that, please go to the redsdentist.org website. Thank you, everyone who attended this event online. We are offering these courses virtually, so you can do this through the internet as well. And we don't have to feed you. Also, for those who want to throw caution to the wind based on what we've just heard, there are some cookies still left and some pasta as well. So please help us clear the field, because certainly I don't need the cookies.
Thank you. That was a lot for 3 hours. Thank you so much. Clark Gardens over there. So our backyard is Clark Gardens. Clark meaning the attorney for Moses. They built the Grand Central Parkway and all the Island Highway. So Moses' attorney was Clark, and Clark donated that property to the Botanical Gardens. And that Botanical Gardens is my backyard. Literally, the back of my property faces that. So we have. No, I grew up in Queens. Yeah, in Queens. I was actually born in Brooklyn and grew up in Queens. That's where I met my wife. You know, we were the Rolling Stones. Well, the Bronx, right? You're either from the Bronx or Brooklyn, and you go to Queens, and then you go to Long Island. That's the routine. True. Manhattan or Brooklyn, right? You know what?